Welcome. Thank you for joining the 7th Annual Infant Health Policy Summit. I'm Susan Hepworth, Executive Director of the National Coalition for Infant Health, and I'll be hosting today's program. I will be joined throughout the day by my colleague Amanda Conchafter from the Alliance for Patient Access, who will help facilitate some of today's discussions. We are thrilled that the Coalition is convening this wonderful event for 7 years now, and we want to thank our co-hosts, the Alliance for Patient Access and Institute for Patient Access. We also have a number of generous sponsors who have made today's program possible. Hand to Hold, Janssen, Mallinckrodt Pharmaceuticals, Merck, Prolacta Bioscience, Sanofi Pasteur, and Sobi. I want to take just a moment to highlight the work these organizations are doing to improve the lives of infants and their families. Hand to Hold is an amazing organization providing peer-to-peer support for NICU families across the country. Janssen is working to find treatments for rare diseases impacting the fetus and newborn babies. Mallinckrodt Pharmaceuticals is the maker of an inhaled nitric oxide therapy helping premature infants who have difficulty breathing. Merck and Sanofi Pasteur are two companies working on vaccine-like products to help protect all infants from RSV. Prolacta Bioscience provides life-saving nutrition to critically ill and premature infants. And Sobi has the only FDA-approved treatment to help protect premature infants from RSV. We appreciate the work they are doing for these vulnerable babies, and we are grateful for their support of today's summit. You can learn more about each of our sponsors by clicking Sponsors at the top of the webpage. On the live stream page you're currently viewing, there are two boxes, one for Q&A and polling, and the other for interacting with fellow attendees. Some of today's segments will feature an opportunity for audience Q&A, or we might ask the audience some questions using the polling feature. If we have time for questions during some of our segments, type those into that box, click Send, and your question will be added to the queue. And I'll let you know at the beginning of each segment if we have allotted time for questions. And please interact with fellow attendees using the chat box on the right side of your screen. And if you are on social media, we encourage you to use the hashtag InfantSummit21 and follow us on Facebook at Coalition for Infant Health and on Twitter at Infant Coalition. We will also post links to those social media tags in the chat box. As you scroll through the live stream page, you'll find information for all of today's speakers, the agenda, and a variety of videos and resources from the Coalition. We would encourage you to download those and share them. You can also find more resources and information about the National Coalition for Infant Health at infanthealth.org. Now, it's my pleasure to introduce Ashley Randolph, who will deliver the summit's opening remarks. Ashley is a mother of 3 preemies, founder and president of Glow Preemies, and is a co-founder of the Alliance for Black NICU Families. Ashley, take it away.
Good morning, and welcome to the 2021 National Infant Health Policy Summit. During today's program, we'll hear about the challenges and triumphs of infants, their families, their communities, and their healthcare providers. We'll examine the policies that shape infant care, and how advocates can make these policies stronger, better, and fairer. These are topics that I, like many of you, have a personal stake in. You see, infant health policy became personal for me a little over 10 years ago when I was expecting my first child. At that time, I suffered a condition called hyperemesis gravidarum. It caused severe nausea and vomiting during pregnancy, and it made me a risk that no doctor wanted to take on. As sick as I was, I had to find the energy to advocate for proper medical care for myself. And then, when my first child, my son Aiden, was born prematurely, I found myself in the place I never thought I would ever be, the neonatal intensive care unit. There, I had to advocate once again because I, like other African American families, discovered gaps in the system. My baby and I did not always get the information, the respect, nor the care that we needed. Navigating the NICU after you just come through the enormous stress of a premature birth, that's difficult for any parent, but it's especially hard when you're met with preconceptions, stereotypes, or judgment from the very system that's meant to help you. But I don't give up easily. Like many of you joining today, I knew that the challenges I faced were an opportunity to do something more, to make the NICU experience smoother and better for other families of color. Today, I am the proud creator of Glow Preemies, a nonprofit dedicated to connecting NICU families to the information and resources they need for up to 18 years after birth. I also co-founded the Alliance for Black NICU Families, a national organization of groups dedicated to policy change to improve the experience of NICU families. These endeavors have given me a powerful glimpse at what we can do together when we set our mind towards the single goal of helping infants. And I know that same goal, that same collaborative spirit, brings us all here today. We'll cover a lot of ground in the next 3 hours. We'll enjoy a keynote address from U.S. Representative Nanette Diaz-Barragan of California's 44th District, an advocate for families, maternal mental health, and reducing health disparities. Today's program will also explore how innovation of medications and medical devices can increase safety for infants, the continuing threat of RSV, and how hospital policies that separated COVID-positive mothers from their newborns had devastating impacts. We'll explore the need to keep safety top of mind when it comes to donor human milk. We'll learn how antibodies, the proteins designed to protect the body, can go airy, putting mothers and their unborn babies at risk. And throughout the program, we'll hear a broad range of viewpoints on how different communities experience parenthood, infant care, and the healthcare system. This is going to be a fantastic summit. Thank you for your time, your energy, and your commitment to improving infant health policy today, tomorrow, and every day, until all infants have the access and the care they deserve. Let's get started.
Sometimes the healthcare system treats infants like they're tiny adults. That's not just inaccurate, it can actually cause problems, especially when it comes to medications and medical devices used to treat infants in hospitals. Caring for babies in the hospital often involves ventilators for breathing support, monitors to track vital signs and lung function, incubators to normalize babies' temperatures, and infusion pumps and tubing to deliver medication or nutrition. Accuracy and precision are critical, whether it's fragile infants fighting for their lives in the NICU or older babies receiving care elsewhere in the hospital. Infants need health care that's tailored to their age, weight, and medical condition. But that's not always what they receive. Instead, they may be treated with devices and medications that were designed for adults, not for babies. That can lead to errors such as unintentional medication overdoses, dangerously high oxygen levels, and variable blood sugar levels. These errors can lead to further illness, injury, or even death. Infants deserve protection and the safest possible health care. That requires policies that promote the development of drugs and devices for infants under 2, and hospital systems that implement the use of these drugs and devices. With more tools designed specifically for tiny patients, more babies can receive the best hospital care. To learn more, visit infanthealth.org.
Thank you to Ashley for those opening remarks, and thank you for all that you do for the infant health community. You just watched a brand new video from the National Coalition for Infant Health, which is a great primer for the first segment of today's summit, Innovating for Infants, They Are Not Tiny Adults. Like the video outlined, we're going to talk about the need for innovation for this very specific population and what some of the barriers are to this innovation. So, I am joined by Dr. Mitchell Goldstein, Professor of Pediatrics at Loma Linda University Children's Hospital. Dr. Goldstein also serves as Medical Director of the National Coalition for Infant Health. And we also have with us Dr. Patty Bondurant, the Chief Quality and Patient Safety Officer at the University of Kentucky Healthcare. Mitch and Patty, thank you for joining us. Mitch, I want to start out by asking you to share an experience with us when a new innovation, or perhaps the need for a new innovation, impacted the care you were giving to a vulnerable infant.
This is one thing that for me is at times painful, at times hopeful. It was early in my career, and it involved some of the research I was doing on specific devices, pulse oximetry. And these devices were devices that were designed to measure oxygen in patients, basically non-invasively. The issue was that these devices were largely made or largely tuned for adults. And oftentimes when we put them in place, they didn't work the way they were designed to. On one occasion, I was taking care of a baby who came in ad extremis. This is something we say when a baby is very close to death. And this baby really was not doing well. And we used at that time, conventional pulse oximeter, which didn't have the algorithms, it didn't have the necessary sensitivity. It didn't have the ability to monitor this baby where this baby needed to be monitored. It didn't address the incredibly low perfusion that this baby had. At that time, fortunately, I was doing a study with an innovative, newer oximeter, which had better algorithms and better technology. And this oximeter was able to read where this other one was not. And although I had nurses and respiratory therapists saying, look, the conventional therapy, conventional monitoring indicates that we really shouldn't go on, the newer device, the one that I was studying, indicated slow but steady improvement. And this was really, I think, the first point where I realized how important it was from a standpoint of technology, that we have technology that was specifically designed for the population, in this case neonates, where we were using it. And this technology for this baby at that time made all the difference.
So, Patty, you have spent a better part of your career focused on helping institutions provide the best care possible to infants, and you've been involved with a lot of different organizations who are working on innovations for this particular population. So, what do you think is the biggest challenge or roadblock to innovation specifically for the neonatal population?
Good morning, Susan, and good morning, everyone. Thank you for having us this morning. You know, the challenges abound in the NICU environment are for many reasons. With my quality and safety hat on, one of the foundations that we need to pay attention to as we think about innovation is how do human factors and systems thinking and the culture of care impact what we do in the NICU. That's foundational for everything that we do, or should be. And layered over that is the difficulty in generalizing some of the results of studies that have been done, even in the pediatric population, given the severity of the range of illnesses that we deal with, gestational ages, and most of our level 3 and level 4 NICUs. I think many of our challenges are often device related and certainly impact how we deliver care and have over the last 20 years since I've been involved in the NICU. There's a scarcity of well-tested, safe and effective devices, and all of us that worked in the NICU know that to be true. How do we define the difference between a TPN line and a breast milk feeding tube? The invasive procedures that can lead to healthcare acquired infections in our immune compromised population because of incomplete skin development or midline external abnormalities that some of these babies are born with leaves the NICU population extremely vulnerable to all types of infections that we may not have the tools to deal with on a day-to-day basis to date. And then last, I think about the medication and the TPN nutritional errors, and how do we develop proper instrumentation, the right size of volume syringes, the right types of tubing, the dosage calculation packages that are so imperative when we think about being able to deliver effectively and safely the right dose and the right medication to patients. And lastly, one of the most important things that I think about is the changing weight and the maturation with many of the babies that stay with us in the NICU because of their long length of stay. I think those are some of the challenges that face us on a day-to-day basis.
Yeah, thanks, Patty. And the point being that this population has its own set of unique challenges that we need to take into consideration. So, Patty, you just outlined some of the challenges, but there is some good news. At least maybe there are interesting programs and startup organizations that are working collaboratively to bring new innovations to market. So I'm wondering if you can tell us about some of those programs.
Yeah, thanks, Suzanne. I'm happy to, because I'm happy to say that I've been involved, not just as a nurse leader, to help bring some of what the innovation has been over the last 10 years to the NICU market. There are several companies that are made up of public-private seed stage investors where their mission is to be a trusted partner to all of us in healthcare, to transform what we have as ideas into high potential life science and digital companies that help with the convergence of life science, physical science, and our computer sciences, which we know are ultimately breakthrough innovations for us in healthcare that for those of us that are in the day-to-day don't have the opportunity to do that. I have been involved with a company called the Institute for Pediatric Innovation that's out of Boston. It originally started as a coalition of pediatric-focused hospitals, innovators and collaborators committed to ensuring that all children have access to the right devices to deliver safe care. One of the things that we were able to accomplish over the last several years is we held, there was a thing called the Clinical Innovation Catalyst Program that was developed at IPI, or the Institute for Pediatric Innovation, and it engaged 5 different children's hospitals across the country with a program that was focused for specifically clinicians, mostly nurses, to help design and find product improvements that could reduce the occurrence of things like unplanned extubations, central line infections, CAUTIs, and pressure injuries. What's happened since then? We did all this brainstorming, and so these nurses came up with some great ideas and a respiratory therapist. What ended up happening is that IPI pooled the rights to all the intellectual property and the know-how arising from this catalyst program remember the seed of this was coming from the bedside, which is really remarkable, and provided the opportunity for equity partners who were very interested in this work if the ideas were commercialized. And in 2018, IPI licensed all the rights for these designs to another company that is a spinoff from IPI that is now looking at designing these products to bring to market. I think that's a revolution that needs to happen. It's something that we all need to pay attention to and make sure, as a reminder, that our NICUs are really closed environments for many people in the hospital, never mind those outside of the hospital where we can garner support. So thinking about how we bring innovation into the space, it is pretty sacred for most physicians and nurses and families that are in the NICU. This is just one example of one of the great companies that I've had an opportunity to work with.
That's great, Patty. So I'm going to have another question for Mitch, but before I go to Mitch, we're going to do our first poll of our audience today. So it's a multiple choice question, and I'm going to read it to you, but you're also going to see it in the poll box on the webpage. So it should just be underneath where you're currently viewing the live stream. There's a box that says Q&A and polls. So if you click on polls, you should see this here. So here's the question. In the last 20 years, how many new therapies have been developed and approved specifically for the infant population? So there's 4 options here. Is it A, none, B, less than 5, C, less than 10, and D, more than 10? Okay, so I've got my results here in front of me, and we're going to take a look at it. We'll give it just a few seconds to calculate. And it's looking like our audience is pretty in the know. The correct answer is B. It is less than 5. So we have more than 50% of our audience who got that question right. So that's really good news. So Mitch, I would like to hear from you, from your perspective, what do you believe is the biggest barrier to getting new devices and medications developed specifically for infants?
This is a really good question, because when we look at the field of medicine today, we see a lot of innovations in a lot of different areas. But the one place we don't see it as much, or at least as much as we should expect, is the area of the newborn. And a large part of that has to do with the emphasis and where things are going and certain contracts that have been set up. It involves purchasing contracts, areas of exclusivity, and at times purchasing according to what is on the inventory or the group purchasing organization docket for a particular hospital. Oftentimes that means that people with innovative products or people with innovative designs have to first negotiate not necessarily something based on best practice, but negotiate on something that would fit into an inventory or into an existing hospital relationship. This means that a lot of times innovative new companies, companies that are startups as mentioned, have a difficult time finding their way into hospitals because at purchasing, they're not on an approved list or an approved docket. This creates an obstacle. And again, we don't necessarily lack for innovation, but we lack for a means of getting this innovation, these new devices, these ones that offer quantum improvements of care to the patients who need it the most.
Yeah, Mitch, I kind of want to reiterate what you said there. So, you know, we may have new devices and therapeutics coming to market, but if the patients can't actually access them, you know, sort of then what is the point? And we know that that also then discourages future innovation when these new products come to market, but there are significant access barriers. So, Mitch and Patty, this is a question for both of you, and this will probably be our last question, but you've both talked about the roadblocks that we face. So I would like to hear from you what you think policymakers can do to encourage the development of medications and devices that are designed specifically for infants. So Patty, I'll let you go first.
Thanks, Susan. I think most importantly, our policymakers, we need to create some intention about this work. and some, along with some visibility. I would say our policymakers probably don't have the visibility that they need because we haven't created these intentional relationships that we need to have to be able to bring the visibility to the needs of the NICU population, nor to Mitch's point, being able to accelerate not only the development, but the delivery of these devices to the hospital with these non-traditional and private sector relationships that need to be built. Policymakers need to be in the know. Do I have I don't know that I have a roadmap for it, but I think there is an engagement of our private sector, and the intentionality of hospitals to reach outside the doors for the help from our policymakers and our innovators in the private and public sector to bring visibility and some acceleration of innovation to the NICU.
Yeah. And Mitch, what about you?
Well, I think we've seen some progress made, and that progress is largely in the realm of pharmaceuticals. Companies do get a certain exclusivity credit for developing certain pharmaceuticals and including pharmaceutical trials for children in the development of existing drugs. So this can result in a pharmaceutical company being able to get 6 months of exclusivity on a particular development of pharmaceutical in development, and this can be very lucrative for them. But it really doesn't go far enough, and we still see a problem with respect to devices. And again, even if a company develops a notable pharmaceutical or medical device, how does it translate? How does it get to the bedside? And oftentimes these barriers that require legislative oversight, these barriers that require a little bit more effort to get through, are very, very important in terms of actually getting these medical devices, these pharmaceuticals, to the babies who need it most. I mean, the context is that these are little people, but little people doesn't mean little funding. Their problems, our problems as clinicians, are just as big as anyone else's.
Thanks, Mitch. And Patty, like you said, I mean, this issue kind of needs more visibility. Policymakers need to understand the unique needs of this population, and that is one reason that we decided to highlight this topic at today's summit. So, Mitch and Patty, thank you so much for joining us today. Thank you for sharing your expertise with us, and I know I'm certainly looking forward to seeing what new innovations are going to be coming to market for this population in the coming years. So, thank you for joining us.
Thank you for having me.
As Ashley mentioned in her opening remarks, throughout the day we are going to hear a variety of viewpoints from underrepresented communities to better understand how we as advocates, policymakers, and clinicians can better serve these patients and their families. For our first viewpoint of the day, I had the opportunity to talk with Wakako Eklund, a neonatal nurse practitioner in Nashville, Tennessee, and an affiliate associate professor at the Bouvet College of Health Sciences at Northeastern University. Wakako, who is originally from Japan, is going to share some of her experiences helping Asian families, many of whom face a major language barrier, to receive optimal care and have positive experiences in the hospital setting. Here's my conversation with Wakako.
Wakako, thanks so much for joining us today.
Thank you so much for including me in this program.
So Wakako, you practice in the Nashville, Tennessee area, and several years ago, Nissan moved its headquarters there as well as a lot of its suppliers. So there was really an influx of a lot of different people from different Asian countries. So we had the Japanese, Korean, and Vietnamese populations moving to the area. So I would like to hear from you your perspective on some of the experiences that you witnessed with some of these people from these countries who may not be speaking the English language as well as you and I do, and maybe a couple of examples of some specific experiences you recall.
Sure. Yes, we have very multi-ethnic population in Nashville now, and I remember having a very scary moment with a young mother carrying a 23-week and several day baby. Husband spoke English, but he was out of town on business trip and we couldn't reach him. And she reported to one of our hospitals in preterm labor. One of our neonatologists that I work with called me. I was off, I was home, just begging me, is there any chance you can translate? Because the complexity of how to or what to think about 23, 24 weeker is so difficult. And she did not want the translation to go wrong by using the phone interpreter that day. And I spoke to the family. Throughout the stay, we had challenges, sometimes not having that really good translator to explain sensitive matter. We've had a couple of other Japanese delivering preemies, and some of the challenges are always very similar.
Okay, so it sounds like language may be a
Yes.
specific barrier that's getting in the way from these patients, experiencing optimal care and good experiences in the hospital setting. How do you think that then we or hospital administrations or policymakers can help to address some of those language barriers?
Sure, not just to require the hospital's institution, healthcare institution to have some type of interpreters or translation service available, but to require, to guarantee some level of quality. So misunderstanding or misinterpretation can be minimized.
Do you have an example of
Yes.
one experiences?
This was sad, but we have head ultrasound within about a week of baby's birth when the child is very premature. Well, the head ultrasound showed that baby had grade 1 intraventricular hemorrhage. We call it grade 1 IVH. Well, the translator on the phone did his best, but interpreted as that your baby had the worst kind of a brain hemorrhage. He understood grade 1 as the worst. He did not know grade 1 is actually the lightest case. And that caused a major mental, psychological distress on the mom and dad at the bedside.
So how do you think that then policymakers, advocates, clinicians, other providers can do to try to reduce some of these language barriers that are happening for our Asian populations?
Well, first of all, I think that if the policy can somehow support to develop a really good go-to resources that are common language, common physiology and diseases among the neonates, so that somebody who hears intraventricular hemorrhage can quickly find out that, oh, grade 1 is the least devastating, instead of guessing grade 1 must mean the worst. I would love to see some type of training or resource developed that can be available.
And then what about just from kind of the nonverbal side? You and I have talked about this and just how important that nonverbal communication is when there is very clearly a language barrier.
Sure. When the language barrier is so severe, moms won't talk to the nurse or ask questions. So often she can be misinterpreted, or that she does not want to be talked to. She does not want to chat with a nurse. But instead, you can make the mom to feel like she's neglected. So having the verbal, smiling, or point to the baby and say, thumbs up, baby's doing well. Gesturing to say, you count, your presence counts. Assuring that mom or dad, those kind of a positive sense would be highly beneficial.
Yeah. And the last thing I want to ask you about, something you and I talked about, was just how some of these language barriers and these experiences can really color in a very negative way.
Yes.
Especially if there is a loss of a child. So I'd just like you to address that kind of as our last final point.
Sure. One of the mom texted me one day to say, I'm not treated the same like other white families, just because she recognized how nurses didn't interact with her as frequently, and she was so angry. And the outcome was good for her baby, but if frequent occurrences like that accumulate in someone's heart, can you imagine her perception of the quality of care she received? Even if the healthcare providers gave the best care they could, she can carry the negative experience or perceived negative quality forever.
Yeah, and that would be very unfortunate, of course. So, I mean, it sounds to me like we perhaps need better quality translation services. And like you said, some type of a resource so that when these translators get these very complex topics for this neonatal population, that they have a little bit a better way of communicating with these parents so we don't have those miscommunications. And then, of course, like you said, it's empathy, it's understanding, it's those nonverbal cues that are so important when we do have those language barriers. So, Wakako, thank you so much for sharing your viewpoints with us today.
Well, thank you very much for this opportunity.
Well, I hope you enjoyed that discussion with Wakako as much as I did. She certainly has a passion for helping to better serve the Asian community, and we appreciate all of her work that she is doing. I look forward to the other viewpoints that we will be highlighting a little bit later in today's program. But in the meantime, I'm going to turn things over to my colleague Amanda Conchafter from the Alliance for Patient Access to lead our next segments about respiratory syncytial virus. Amanda?
Thank you, Susan. Good afternoon. I'm Amanda Conchafter from the Alliance for Patient Access, and it's my pleasure to moderate today's discussion on respiratory syncytial virus. RSV is a seasonal virus whose cold-like symptoms can turn severe, even deadly, making RSV the leading cause of hospitalization in infants under the age of 1. RSV is a risk to all infants, but it affects Black babies in particular. These infants are more likely than white babies to be born prematurely, and they are more likely to encounter the risk factors associated with RSV. So we'll consider now what happens when firsthand experience with RSV becomes the impetus for much needed policy change. And for this conversation, I'm pleased to welcome Megan Jones, an attorney, Iowa state legislator, and a mother turned advocate who watched her own children struggle with RSV. We'll also be joined by Dr. Suzanne Stabler, clinical professor at Emory University and a longtime policy advisor for the National Coalition for Infant Health. Thank you both for joining us. So Megan, not so long ago, you found yourself taking an ambulance ride with your son that you probably never anticipated. Can you tell us about your family's experience with RSV?
Sure. So we have 4 kids. Our first son had RSV. We really anticipated it. It was going around through daycare. We, took him in, got the confirmation, took him home, just monitored him, and it was really the ideal case of RSV if you're going to have it. Our third child, Archie, he ended up doing a 2-day stint in the hospital in August of 2019, but then back again in February of 2020. And there's his picture from that August journey. But in 2020, it got really bad, and overnight they decided to transport us to a children's hospital, and that ambulance ride is certainly one that I'll never forget.
Thank you for sharing your story. I know that must have been difficult for your family. Dr. Stabler, we know that stories like Megan's most often occur during RSV season, early fall through winter. But this year we've seen a new trend that might concern healthcare providers and families alike. Can you tell us about that?
Certainly. So initially, Amanda, we saw a worldwide decrease in RSV cases during the pandemic. And most experts thought that was related to the use of masks and social distancing, as well as increased public awareness about hand hygiene. It is really unclear. It was unclear at the time if the 2020 to 21 season would continue to have markedly reduced cases or if it would just be delayed. Well, unfortunately, as we now are aware, it was just delayed. So on June 10th, the CDC actually issued a health advisory to notify clinicians of the increased RSV activity in the US outside of the normal season of October to March. And then in August, just last month, the American Academy of Pediatrics released interim guidance on the administration of palivizumab during this atypical season. Unfortunately, pediatric ICU beds across the country are now full of infants and children with either RSV or COVID-19.
Right, and palivizumab is the prophylactic treatment for RSV, for those watching who that may be a new name for. So Megan, I want to come back to you. So you're from a rural area, Clay County, Iowa, and thinking back, how did your son's experience with RSV inform your thinking about access to proper health care for rural or underserved populations?
Yeah, I mean, transportation is really a huge issue in my area. We are kind of in the center of Northwest Iowa. And when they informed us that Archie was going to have to be transported, it was the middle of the night. I had no resources. I couldn't even get back home. I was 20 minutes out from home. They were transporting us over 2 hours away. I didn't know if we were being transported via helicopter or an ambulance. And at that point, I just knew that my baby and our financial security looking forward were really in jeopardy. And then I even asked, I said, how do we know how we're being transported? And they said, really, it's just whatever team shows up. And so that was really a punch to my gut and to my mommy heart, knowing that I really couldn't control our future. I couldn't control my baby's health care. And then once we got through that, it ended up being an ambulance that picked us up. But once we got through that 2 hour car ride home, or 2 hour car ride to the children's hospital, the personal logistics, the emotional toll, I had no one there to bring us clothes or to bring us a car or to bring us food. I didn't know what was in store for us. And actually, it ended up being that a daycare provider that I had when I was in the 2nd grade, her mom came to the hospital and gave us some supplies to get us through the night. So thankfully, social media was able to help push us through until my husband and some family could get to us. But I remember feeling so alone and knowing that my son felt even more alone and scared. So it was really that transportation that was such a huge barrier for us to get through to where we needed to be, to put him in the hands of the best healthcare providers that we could get him there. And then even once we were there, I remember thinking, we left a team of nurses who knew me from high school, who knew my son's name because we're friends on Facebook, to knowing that we didn't know anybody there. We didn't know any of the staff. And I can forever remember sending him down for a CT scan, and they kept referring to him as his legal name, and he wasn't responding. And it was because he always goes by Archie, and they didn't know him as anything other than his legal name. And so there was just some education barriers that we needed to get through, but it was certainly an eye-opening experience for me as a mom, but as a legislator too, about what rural Iowans are facing every day when they make healthcare decisions.
Thank you for that. Now, Dr. Stabler, access challenges are not new for families and those familiar with RSV. In addition to your work in the Nicu, you've also been an active advocate for infants and families facing RSV for some years now. Where do you see the biggest need for change?
Well, Amanda, it's really difficult as a provider to see infants struggle with RSV in the NICU or PICU, especially because we know it can be prevented. And then hearing stories like Megan's just kind of rips at me. Prophylactic treatment for RSV has been FDA approved since the late 1990s. And unfortunately, though, insurance companies follow the Red Book guidelines for dosing and coverage. So many of our at-risk infants are denied treatment. And navigating that whole appeal process and everything can just be overwhelming and daunting for parents and providers alike. So unless the baby is born severely premature or with specific chronic health conditions, they won't qualify for coverage. And this is even with the new interim season coverage that was just released from the American Academy, they didn't expand which babies could get treatment. They only expanded the timing of the dosing in order to meet this new seasonality that we're seeing through the pandemic. So the issues with insurance coverage restrictions are all around, especially in the NICU. And this tends to impact then medical innovation in our area, as we've already talked about. So all of this is concerning because we really need companies to continue their work in developing vaccine-like medications for RSV and other diseases that we see in this population. But we have to have improved policies to expand access so that our patients can benefit.
Right. Now, Megan, as a state legislator, you bring a policy perspective to RSV as well. So reflecting on your experience, how do you think that policies, whether it be state or local policy, national policy, health plan policy, how can they do better by the infants and families who face RSV?
Yeah, the first thing that legislatures can do is pass resolutions and really get the word out about what RSV is, and make sure that people know about RSV going around in their area, and passing resolutions and really honing in a public relations perspective to RSV. But at the same time, I think there are some policy pieces that we can handle on the state level. Iowa is one of the most heavily licensed states in the nation, and we've really tackled healthcare when it comes to our providers and making sure that rural Iowans are able to have access to a healthcare professional in their time of need. And so I think licensure is something that we can all tackle to make sure that we have providers available. We're never going to replace doctors or nurses. Those are some of our best resources when it comes to tackling RSV. But at the same time, I think there are elements of RSV that make it so that we can get easier access. So we can get those tests done pretty quickly. When Archie went in the second time, it was really caught by an ARNP that happens to have open doors on Sunday mornings. And so had it not been for her and her ability to do those testings, we would have been stuck until Monday morning, which is really when things got very, very serious. And so I am so thankful that we live in a state and have those opportunities for folks like her to have access to that kind of testing and those doors, and have that Sunday morning availability, that ARNPs do exist in our state, and that we are able to utilize those services in rural Iowa.
Thank you, Megan. And thank you, Dr. Stabler. We appreciate the work you both do. It's been a valuable discussion. So now I'll turn it back over to my colleague, Susan Hepworth.
Thanks, Amanda. And that was a really great discussion, a lot that we can learn from that. So before we move into our next segment, I'm going to introduce a quick video similar to what we've been talking about today about RSV.
For young children, it can mean hospitalization, lifelong complications, even death. But when it comes to respiratory syncytial virus, or RSV, parents just aren't prepared, and that's a problem. Of specialty healthcare providers, about 2/3 say they always or often see cases of RSV in their practice. 77% say it's the most dangerous illness for children under age 4. And 96% say it's the most dangerous illness for premature babies. But parents, just 18% know a lot about RSV, and only about 1 in 5 say they are very well prepared to prevent the virus. That can also mean parents aren't prepared to fight through insurance barriers, which more than 2/3 of specialty healthcare providers say block children from getting preventive treatment. Increased RSV awareness can mean better protection, better access to treatment, and better health for infants and children. Don't want RSV to take you by surprise? Learn more at infanthealth.org.
And I am pleased to introduce our next viewpoint from the LGBTQ community, shared with us by Dr. Curry Bordelon, a neonatal nurse practitioner and assistant professor at the University of Alabama at Birmingham School of Nursing. Curry, thank you for joining us.
Absolutely, thank you for having me.
So, Curry, you and your husband are the parents of 2 adopted children, one of whom was born 8 weeks preterm. And while you did experience quite a lot of challenges during that adoption process, luckily they did occur in an area of the country where providers and staff were pretty open-minded, and you didn't yourself experience much bias because of your same-sex marriage while you were staying in the NICU. But we do know this is not always the case, of course. So you're a professor, and you're also a member of the LGBTQ community. I want to know what you are teaching your nursing students and what you're talking to your colleagues about bias, whether that be conscious or unconscious.
Certainly, and thank you for having me. Yeah, it's one of these things that in education, we're always trying to expand the knowledge that we're providing for our students to better prepare themselves to take care of the patients. And as we know, students are part of communities as they're caring for these patients and learning to care for these patients of a very diverse community. It's not monolithic. It's not in a single entity. And so that's one of the things that as we become more and more diversified within the United States, and we're caring for more and more people from different countries and different backgrounds and ethnicities and parts of different communities, it's always very important that you recognize where your biases lie, because what we believe as what a family is or looks like may not be what the family actually is. So it's very important that we don't automatically come to that caring environment or come to that space where we're caring for others and automatically assume, we get this all the time. Oh, where's mom or what have you? Because it's not uncommon for us to go to dinner with the kids and we're sitting at tables. Oh, it's so nice that you gave the moms a day off or something like that. And it's automatic in certain communities and certain geographic areas that that's the assumption. Well, in healthcare, you can't assume that either. It's really about understanding that family unit. So when we educate students and we're educating the next generation of caregivers, we really want them to understand that families are diverse. They're different. They're, whether it be different races, different backgrounds, different genders, gender identities even. So it's very important that you don't carry your assumptions into that space of caring.
So, Curry, do you think there is a tendency, though, among some providers to disengage or perhaps avoid engagement altogether with patients that aren't like them, whether it's sexual orientation, race, or culture? And it may not be, they're not doing it out of ill intent, but perhaps it's just a level of discomfort.
Yes, I think the overwhelming answer to that in many cases is yes, because avoidance can be a coping mechanism for some people because they don't want to say the incorrect thing, or they don't want to offend someone, or they just don't know how to approach it. Maybe they've not been taught, or the culture within that caring environment is not one of openness. So sometimes they might struggle to understand how to approach something different or someone different or a family that's different. So it's not uncommon for people to disconnect or to avoid caring for a particular family unit or to avoid a situation of communication out of fear of not offending or not understanding how to. I want to stay in my safe space that I know how to respond and not take that opportunity to learn more about a diverse community.
Yeah. And just to follow on that, Curry, so have you ever been in the situation when someone perhaps has felt uncomfortable asking you a question? Like, how would you prefer people to handle that? Do you want them to just be straightforward with you and say, hey, how should I talk about this? I mean, what is the best way for us to approach those situations?
Sure, that's a really great question. And one of the biggest things I always tell people is it never hurts to ask. Because it's like we talked about just a minute ago, it's immediate instinct not to want to approach a subject or to avoid a subject, whether it be gender identity or family dynamics. And so the automatic response is avoidance. But what we always try to have people to do is encourage that engagement. And it never hurts to ask. I will tell you from being in the community, it's actually more powerful for you to say, oh, well, what gender do you identify with? Or, oh, what does your family look like? That sort of thing. As if you ask that question, you're inviting that conversation, that dialogue, because the overwhelming thing is for us in the community is we're just like any other community. We've been together for 18 years. We have 2 children. We, retirement plans, travel and families that we care for. So it's just like any other family unit that's out there. It's really about our family is, it's not the same as others, but it's all a family. So it's really about asking. It never hurts to ask and be engaged versus avoidance, because asking and wanting to be engaged has a lot more value than disengagement.
Asking and engaging, I like that. So my final question for you, Curry, is what can we as advocates, policymakers, providers, everybody who's listening in today, what can we do to better serve the LGBTQ patients and ensure that they have optimal care and the best experience in the hospital setting?
Absolutely. Well, there's a few small things that go a long way, is the way I look at it. Whenever legislation or policies or protocols are put in place, avoid the assumptions of mom, dad. Avoid the assumptions of filling in the blanks on admission paperwork for patients. Mom, dad, or mother, father. That we get that all the time. In fact, we had an opportunity in our pediatrician when we first adopted our first child, is filling out the paperwork, mother's name, contact information, father's name. I said, what's the possibility of changing this to parent 1 and parent 2? The office took that as, wait, this is a great opportunity. We have people of same-sex couples that come to our office. That's a great way. Well, they took that small change that went a long way. I can't tell you how many times on a daily, weekly, monthly basis that we're filling out something for one of the kids and it's asking for mom and dad information. That assumption, although might be the most common, is not diverse. It's not fully inclusive. So as legislation, as administration, as you're doing things within leadership, within healthcare facilities or healthcare practices, don't make that assumption that it's a mom, dad. Make it more of parent 1, parent 2, or parent. So that way you have an opportunity to list that and it shows that level of inclusion. That's one small example of the inclusivity of that one motion of just making it about parent 1, parent 2 versus an assumption of mom, dad. And that goes with it, advanced directives, signatures on consents to treat, discharge paperwork. So there's so many, all the paperwork with the demographics within an EHR. So I think there's a lot of opportunity in those small movements that can go a long way for inclusion.
Well, Curry, I wish we had more time to continue this conversation, but we don't. But I want to thank you for joining us and really appreciate all that you're doing to help prepare the next generation of healthcare providers to be a little bit more aware, a little bit more open, and a little bit more understanding of the many different patients that they will encounter in their careers. It's not if they encounter, people in their career who are different from them, but they will, and we all know that. So, Curry, thank you so much for joining us.
You're welcome, and thank you for having me.
In our next segment, COVID-19 Mother and Baby Separation World Impact, we're going to learn about what happened to many mothers and babies around the world during the height of the pandemic in 2020. As the title of the segment suggests, many babies born during the pandemic were separated from their mothers and families for a period of time. We'll learn about why this separation occurred and its impact on babies and families. For the first part of this segment, I am joined by Dr. Johanna Costenzer, Head of Scientific Affairs at the European Foundation for the Care of Newborn Infants. Johanna, thank you for joining us today all the way from Munich, Germany.
Thank you, Susan, for having me.
So Johanna, your organization recently released the results of a survey about what was happening to families and babies during the COVID-19 pandemic. I'd like you to start by giving us some background about the survey, why you conducted it, and how you conducted it.
Yeah, sure. So we conducted a global survey to explore parents' experiences with regards to the impact of COVID-19 and the impact of COVID-19 related restrictions on neonatal care. And we started with this project because when the pandemic hit, so a bit more than a year ago, we grew increasingly concerned about the impact on the provision of care to preterm-born, to sick, and to low birth weight babies in neonatal intensive care units. And because of this concern, we started to have biweekly calls with parent organizations in our network. So those were parent organizations not just in Europe, but actually globally. And these calls were hosted by Silke Mader, who is also the head of our organization. And what was voiced in these calls was a concern by several of the parent organizations and parent organization representatives in the network, that parents were actually having inadequate access to their child as a result of the COVID pandemic and as a result of the related restrictions. And on top of this, also other restrictions occurred. Oxygen masks were taken away from the neonatal units. Many other measures were put in place that were actually, leading to negative and severe consequences for the infants and for the infants who were in particular need of healthcare. And in particular, the separation of the baby and the parent, however, also has severe short and long-term consequences, not only for the infant, but also for the family as a whole. And this was, of course, concerning and still is. And because of this, we then decided to carry out a multinational survey among parents with babies in neonatal intensive care units around the world during this first year of the pandemic. And as I said, the aim was to explore the consequences of the COVID-19 situation and the related restrictions. And we therefore also asked questions in different fields with regards to family-centered care. And those covered, for example, questions on infant nutrition and breastfeeding, but also covered the topic of parental presence and skin-to-skin care. We also included questions on mental health and also health communication. And in order to set up this survey and the study as a whole, we also set up a collaborative group consisting of interdisciplinary experts from many different sectors, also from parent organizations and professional healthcare societies. And all of those members of this group then also helped us to first translate the survey and then finally disseminate the survey in 23 languages. And so we could reach out to many different parents all across the world.
So, Johanna, what results and themes stood out to you the most from this survey?
Well, I think the core message and the core finding of this survey is certainly the separation of parents and infants. So in total, we collected data in 56 countries all across the world, and more than 2,100 parents shared their experiences. And from their experiences, and what we found was that the separation of the parents and infants was in fact really happening. So it was not just anecdotal evidence that we heard about in those biweekly calls, as I mentioned before, but it was really now evidence-based fact as we found with our study. And for example, we saw visitation restrictions in hospitals in general, so not just with the neonatal intensive care units. That was something that was on the news. So people were not allowed to visit family members if they were hospitalized for whatever reasons. But for neonatal care, we also need to acknowledge that parents are not visitors, but they are crucial caregivers of their infant. And so this separation was very concerning and very alarming, and something that we found with our study. And what we found in a bit more detail was that overall, so in this whole set of data that we collected, 20% of the parents answered that they did not have the opportunity to be present with their baby. And 20% is really, it's a lot. It's like 1 in 5 parents and 1 in 5 infants in the end could not benefit from the close contact of their parent, could not benefit from the skin-to-skin contact, and of course also could not benefit from breastfeeding, from hearing the parents' voices, from smelling their scent, and so on. And this separation also has severe consequences, as is also proven in science. So that this close contact has, of course, many, many benefits for the further development and growth of a particularly vulnerable infant. And so this was very, very alarming what we found. And also in our study, parents also had the opportunity to share some more experiences in an open question. And here we actually learned a bit more about the very individual experiences and stories those parents had to tell. And just to share one example was that one mother she mentioned that the first time she was able to hold the baby was at the time of discharge. So, and that was in her case actually was 6 weeks after hospitalization. And that was the first moment when she was allowed to hold her baby in her hands and to actually see it and be with the infant. And that's of course very late. And also it means how well can you prepare to care for such a vulnerable infant when you are, when you don't have the chance to be with the baby when it's already hospitalized. or during hospitalization. And one thing we also found here was that this was not just happening to, for example, COVID positive tested parents, but in fact, this was happening to parents in general. So because also in our survey, we asked as to whether or not the parents had tested positive or COVID-19 positive. And that was actually rarely the case. So we only had a few cases where either the parents or even also the infant were tested positive. However, the separation occurred like in general to everyone. So there was not really a difference that we could observe. And
so
perhaps to share, yep. Mm-hmm.
Oh, go ahead and you can finish, sorry.
Yeah, I just wanted to share one more finding, because we also did a sub-analysis in our survey or in our study, where we looked into as to whether there was a difference between the strength of the lockdown, so to say, or the strength of the restrictions. So looking into whether more severe restrictions when there was only like social distancing in place, or when there was a lockdown in place. And we really found that the stronger the lockdown or COVID-19 restrictive measures, also the more severe the separation was of this parent and infant situation. And here also what we found is that mothers and fathers, or parent one and parent two, were separated to a similar degree, but fathers and partners were affected even more. So they were very often treated as a so-called, I would even say, second-class parents. So that's very harsh, of course, to say, but that's really kind of a result that we found with our study, and it's a very alarming result also, I have to say.
So Johanna, those are fascinating results, and I was writing down some notes while you were talking, but I loved what you said, you know, that parents are not visitors, so why are we treating them as such? But rather, they're an integral part of the care team, and it's about really preparing the parents to take that medically fragile child home to be able to care for them. And certainly the 20% number, or the 1 in 5 who experience separation, really, honestly, it's just unacceptable. So appreciate you sharing those results. So you spoke about some of the key findings from the survey, but what is it that we do with these results going forward, you know, to educate policymakers and those who will make decisions in future pandemics? Hopefully there's never another one, but in other emergencies, you know, global emergencies.
Yeah, well, I think the main take-home message from our study and our project is that we really call for a zero separation policy. Because as I mentioned, parents are key caregivers of their child. They are not visitors, and they also need to be prepared to take a baby home at discharge. And if they are separated, yeah, how can they be prepared in the end? So we at EFCNI, we also decided not only to publish scientific articles on this study, but we will also publish a full report with covering all the country-specific data, and it will be launched in the course of World Prematurity Day this year, actually a week before, during a live webinar on November 11th. And here, this is also going to be a bit more, a larger policy report, I would also say, and policymakers then hopefully also learn from the findings that we will present here, because we also call for this family-centered care approach, which is really important, and a family-inclusive policy must be applied also, but not just in times of crisis. So this is really for, we call for zero separation and family-centered care during crisis, but also in general, because we also know that this is not always taken for granted, also not when there's no crisis situation.
Yeah, and we did paste a link to that survey in the chat, so all of those who are watching today can click on that and learn more. Johanna, thank you for joining us. Thank you for sharing these really interesting survey results, interesting and alarming, I will say. And thank you for the work that the European Foundation for the Care of Newborn Infants is doing to push for a zero separation policy. So thank you so much, Johanna.
Thank you as well, also for giving us the chance to present the results here. Thank you.
Sure. For the second part of this discussion, I had the chance to talk with Ruth David, a neonatal nurse from South Africa and founding president of the Neonatal Nurses Association of Southern Africa. Ruth has been instrumental in her part of the world to ensure zero separation because she also understands the short and long-term implications that this separation has on babies and families. So here's my conversation with Ruth.
Ruth, thank you so much for joining us today.
Thanks, Susan, for having me. It's such a pleasure and privilege to be part of this wonderful summit, and I really hope it's successful for everybody that's involved.
Thank you so much. And I think you take the cake for our participant from furthest away from Washington, D.C. We have a couple of people from London and Munich, Germany, but definitely I think South Africa is the furthest away.
Oh, well, that's very cool.
So, Ruth, I want to start out by asking you, we just heard from Dr. Costenza at EFCNI about some of these COVID restrictions, which were creating a lot of separation between mothers and babies during COVID-19. So I would like to hear a little bit about your experience with that separation in South Africa.
Thanks, Susan. Yeah, it's been challenging for us all. And in South Africa, very variable, particularly between public and private hospitals and between individual facilities. Our national policy does support zero separation of well-term babies, encouraging skin-to-skin care and breastfeeding. However, for sick and small babies, they have to be separated from their COVID-positive mothers for at least 2 weeks, which is really long. And mothers are often sent home to isolate, so aren't even able to provide express breast milk. So this has been really devastating. However, in pediatric wards, where they are able to accommodate the mother and the baby together, then zero separation is supported. In the public sector, we are really privileged to have lodging facilities in most of our hospitals. And KMC, Kangaroo Mother Care, has been well established. And in those circumstances, zero separation is very feasible and is supported. However, in many of the hospitals, these beds, the lodges and the KMC beds, have been redeployed for COVID, and therefore the accessibility to these has been reduced. In the private sector, we don't have lodging and KMC well established. And there, as each wave has come through, they have closed all visiting in their facilities, and this has prohibited mothers and fathers from visiting.
So it sounds like you mentioned in the beginning, it's been variable, whether it's a private sector hospital or whether it's public, and what some of those restrictions are like. So having this zero separation policy, like Dr. Costenza pointed out, is really important. But I think there are maybe some things about your part of the world that people may not be as familiar with, and why this zero separation is even more important, for South Africa.
Thanks. I think I want to highlight in particular breastfeeding. Globally, breastfeeding has been identified as the single most impactful intervention in improving child outcomes. And we've got a 50% coverage target globally for children under 6 months by the year 2025. Initiation of breastfeeding within the first hour is crucial, and the length of any delay is proportionally linked to increased risk of mortality and reduced breastfeeding at 6 months. So in South Africa, we've got a very low breastfeeding rate, and only 32% of our babies are breastfeeding under 6 months. Sick and small babies are particularly vulnerable. So any increased separation obviously is going to negatively impact on our already low breastfeeding rates. In addition, we have a challenge with absentee mothers. Sounds a little bit strange, but the neonatal period is really critical for bonding and the building of maternal confidence in caring for her baby. And the presence of a loving and engaged mother is essential for optimal early childhood development and the ability to cope with or adapt to toxic stress. South Africa has a very high teenage pregnancy rate, and in my province, 18% of mothers are under 19. This has only increased during the pandemic. And this adds to our existing challenge of many babies being cared for by people other than the parent. So the granny or the aunt, sometimes the next door neighbor, or even a sibling, a younger sibling in child-headed households. So prolonged separation during the neonatal period is only going to add to this because it negatively impacts on bonding, it reduces maternal confidence, and therefore increases the risk of neglect, of abandonment, and poor infant outcomes.
Very interesting, Ruth. Thank you for sharing that. So there was a study that was published on kangaroo care in low and middle income countries. It was in the Lancet earlier this year. So I want to read you just real quickly kind of the key finding from that, and then I want you to kind of help us interpret it. It says, the worst case scenario, assuming 100% transmission from COVID positive mother to her infant, could result in 1,950 neonatal deaths. In contrast, they estimated more than 125,000 newborn lives would be saved if frequent and early kangaroo care was practiced universally. So that seems like some very compelling data, but I'd like to hear your thoughts on it.
Thanks, Susan. Yes, I was really excited when that study came out. And it was very timely as with the whole call globally for zero separation. And it was really helpful in simply stating that kangaroo mother care outweighs the risks of COVID-19. So there's a large body of evidence globally that shows reduced neonatal mortality in stable low birth weight babies who receive kangaroo care. And that study that you've just mentioned has also been added to this year by the WHO KMC study group, who've just published a compelling study that actually had to be stopped early because of overwhelming evidence for benefit in showing that preterm babies, unstable preterm babies who received immediate KMC had significant improvement in outcomes. So both these studies emphasize the life-saving benefits of kangaroo mother care and the devastating impact on neonatal outcomes when babies are deprived of this intervention. And this is purely through separation from their mothers.
Yes. So we're almost out of time, Ruth. So I just want to ask you one more question. And really, it's just about some of the work that you're doing in your province in South Africa to ensure zero separation in the event that this would ever occur again, in our lifetime.
Oh, thanks. That's a challenging question. And I think we are all globally trying to look at how this can be prevented. And I think the role of advocacy cannot be understated. Scarily, the pandemic has highlighted globally the need to strengthen health systems and resources, but as always, neonates seem to get forgotten. And a 2008 study found that only 0.1% of maternal newborn funding actually targeted specifically newborn care. And this is despite 47% of under 5 deaths occurring in the neonatal period. Resources have been redeployed during the pandemic away from maternal and newborn and child health to support adults without appreciating the long-term consequences that this has on neonatal and child health. In South Africa, in addition to all of that, in July during our third wave, we actually had an outbreak of civil unrest, and particularly in my province, and this had widespread looting and destruction of property, and healthcare workers were unable to get to work. There was increased food insecurity because grocery stores were destroyed, and mothers in particular were panicked as they were unable to get access to formula. So we are currently developing integrated policies and guidelines for reproductive, maternal, newborn, and child health and healthcare during emergencies. And it is crucial that there's strong neonatal input into these guidelines to ensure that the needs of mothers and babies are highlighted, that infant feeding is protected, and that the presence of the mother is seen as essential and not as a nice to have.
Absolutely, Ruth. Thank you so much for that. And I'm sure that many other countries and provinces will be looking to you and what you are doing and the policies that you are recommending and putting forward as an example for what we can do to ensure the best outcomes for moms and babies, and to ensure that during public health emergencies like we're currently in, the neonatal population is not forgotten about. So Ruth, thank you so much for joining us today.
Thank you so much, Susan. It's just been an absolute pleasure, and I look forward to working with you again in the future.
Me too.
Thank you to Dr. Costenser and Ruth for sharing their perspectives with us and for the work they are doing across the world to ensure policymakers really understand the negative consequences of separating mothers and babies. So to bring us the family perspective on this topic, I had the chance to talk with Marissa DeMiss, the mother of a son born earlier this year with a congenital heart defect. Thankfully, some of the restrictions were starting to lift when Marissa and her family were faced with a very scary situation and an extended hospital stay. But even with some of those restrictions lifted, Marissa and her family still faced a lot of challenges. Here's my conversation with Marissa.
Marissa, thank you so much for joining us.
Thanks for having me.
So Marissa, I think I would like you to start by just talking a little bit about your NICU stay with your son, his diagnosis, and a little bit more background about that.
Sure. I had my son at 36 weeks gestation via cesarean. He was 8 pounds, 11 ounces, so he was a big boy. We were about to be discharged home when the nurse had to perform the infant car seat test. During this test, the nurse placed the infant in the car seat and monitors their heart rate, respiratory rate, and oxygenation. My son, unfortunately, failed this test twice, and on the second one, he struggled to recover his oxygenation. This led us to our 10-day NICU stay, where at the beginning, my son was requiring increased respiratory support to the point that doctors were talking to us about airlifing him to another hospital with better resources. This was really scary thought for my husband and I because my son was in such a fragile state. We weren't even sure if he would survive the airlife over. It took 3 echoes for them to discover that my son had a congenital heart defect, and this was via a telecardiologist. At this time, they wanted to wean his oxygen, which freaked us out again because this meant my son would either tolerate it or he wouldn't tolerate it. And if he didn't tolerate it, we had the chance of airlifing him again to another hospital with better cardiac resources. So me and my husband felt like we were going into like game day battle mode. Thankfully, my son tolerated it and we were able to take him home a couple of days later.
Okay, so it sounds like a very scary experience. So thankfully you got your diagnosis, he was able to be discharged and go home, but you faced some real challenges still while you were in the NICU, in spite of the fact that this happened when a lot of the restrictions were starting to be lifted in hospitals as far as it goes for like who could come and visit and things like that. Mm-hmm. So I would love to hear a little bit more about how some of those challenges impacted you.
Sure. So some of the challenges we faced while we were in the hospital, they just barely started lifting the restrictions. So my husband could be there, but my daughter could not. We're a military family, so our extended family support and childcare is halfway across the country. So we had to rely on a shuffling of friends and acquaintances to watch my daughter. And as a mom, you can't help but feel guilty and kind of like you're neglecting your child for the other one. We also had difficulties while in the NICU taking the back seat in my son's care. My husband and I both are in the medical field. It was also difficult for us to absorb all the information that we were being given because we were living it. Thankfully, at this time, I was able to have my husband's support through all this. If I hadn't, it would have been much more difficult for us.
Yeah, so I kind of want to ask you then, if you had your son just 6 months prior when your husband would not have been allowed to be there with you, how might that experience have been different for you, do you think, without that support?
Had I had my son 6 months prior, things would have been much more difficult because that would have meant just one parent in the hospital at a time. My cesarean journey would have been a lot rougher. My husband was a great support in making sure I walked around the room safely since I was sore from my surgery, and making sure my son was transferred between bassinet and myself for breastfeeding because it was hard for me to move. It also meant only one parent in the NICU at a time. This would have been very hard because I was already feeling lots of emotions while my son was in the NICU. I was very scared that I was going to lose my son. I was very sad because I couldn't even touch and hold my son at a certain point in time. He was so delicate. And I was also very anxious about what the next day would entail for us. And if I did not have my husband's support, I believe all those emotions of fear, anxiety, and being scared would be much more intense. I believe that would have also increased my risk for postpartum depression.
Yeah, and I'm so glad you brought that up. You know, there's been a lot of families who haven't been as fortunate as you have, who did have babies and who experienced hospital stays during the height of the pandemic, when, as you mentioned, they may not have been able to have a support system with them, and just kind of how scary that would have been for them. So I would like to ask you, kind of in closing, you throughout this journey decided that you wanted to be able to help other families, so you got involved with an organization called Little Mended Hearts. And so I'd love for you to tell us a little bit more about that.
Sure. So when my son was first diagnosed with his congenital heart defect, I felt very alone and isolated. There was no resource given to me about what my journey would look like with a heart warrior. Thankfully, I found Mended Little Hearts through a website search. Their goal is to educate, offer peer-to-peer support, and advocate for children with congenital heart defects. They also offer free online resources like their manual, their Heart Guides manual. And in there, it helps caregivers navigate the medical world. And it also let me know I was not alone. Congenital heart defects are the most common birth defects, so there's a lot of support out there for us. My goal moving forward would be helping other families with Mended Little Hearts. I would like to educate and advocate others about congenital heart defects. I would also like to reach more families at the time of diagnosis to make their journey with their heart warrior smoother.
Well, it's fantastic work that you're doing, getting involved with that. And thank you so much for sharing your perspective with us. I know, we wanted to be able to highlight the real life impact that some of these COVID restrictions have had on families. And even though, you kind of came in at the tail end, and luckily you were able to have a bit more support, there are so many families who did not have that luxury that you had. And certainly you mentioned that you and your husband both have medical backgrounds, and even what a challenge that was for you to be able to understand. And so I sort of think about how much that must be compounded for families who don't have a clinical background, where it is more difficult to understand what's going on with their child, and then having that lack of support because of the restrictions, that were placed on the hospitals. So we really appreciate you sharing your perspective with us, and we wish you the best in working with other heart warrior families.
Thank you so much. Thank you so much for having me.
Marissa shared this adorable photo of her 2 children with us. Her daughter Arden is 3 and son Ayers is just about 1 year old, and they are both healthy and doing very well. So we really want to thank Marissa for sharing that very personal experience with all of us. We are now going to pause for a short break. We will be back in 5 minutes.
Welcome back to the 7th Annual Infant Health Policy Summit. I'm Amanda Conshafter. Due to some technical difficulties earlier, we needed to reschedule our conversation with Dr. Martha Dawson, so we're joined by her now. Dr. Dawson is an associate professor at University of Alabama at Birmingham School of Nursing and president of the National Black Nurses Association. In our conversation with her, we'll return to the issue of RSV and consider how the faith community might play a role in finding solutions. Dr. Dawson, thank you for joining us. Can you give us a sense of just what the impact of RSV is on the Black community?
Thank you for having me, Amanda. First, I want to just say that we've heard the term virus so much with the COVID pandemic. However, we cannot forget some of the routine viruses that exposes our infants to great risk. And RSV is one such virus. Each outpatient visits relating to RSV, and sometimes as much as maybe 58,000 hospitalizations per year. And similar to what we discovered during this pandemic, many times your Black and Brown communities are impacted more by this particular virus. So for example, usually when we compare Hispanics and especially African Americans infants, they are probably 3.4 times per 1,000 cases to be African American compared to your non-Hispanic white population, where the children may be only about 2.5 within 1,000. So we can definitely see that, again, there's some disparity when we're talking about the RSV virus.
Thank you for that. And so when you think about solutions to some of the challenges that RSV poses, why the faith community? What role do they have in improving the situation?
Well, I've been working with the faith community around healthcare issues since the early 90s. And one of the things that we have to appreciate is that people are very comfortable in their own communities with like-minded individuals where they may live, work, and play. And so the faith-based organization really provide a comfortable environment for sharing information. And again, when we're sharing that information, we're trying to make sure that we also dispel. The faith-based community is a very powerful resource, not just in terms of the venue, but also in terms of the individuals that are there. And we have to remember that many of these nurses also work and serve within their church on nursing guilds or the nursing units within their church. So there's a very powerful platform for them to be able to educate where they worship.
So thinking back over your years in the profession, can you remember a time when you saw the faith community engage successfully on a healthcare issue like this?
Yes, I can, because for example, we've seen quite a few and use the faith-based organization for a lot of the adult diseases, such as to educate around diabetes, around strokes, and cardiovascular disease. But within the infant space, we've done that with breastfeeding. But more importantly, we, the National Black Nursing Association, for about 3 years had a big effort with the Infant Death Syndrome, SID organization, in terms of teaching parents how to care for their infants and make sure that they did not put them to sleep on their stomach, because this is a parent's worst nightmare. They have to put their child to bed thinking they're safe or have them in bed with them, and then they wake up the next morning and find that the child is not there. So we had a big push for that within the faith-based organization. And we did some unique things such as going to baby showers, going to Wednesday night women prayer services, and just holding health fairs within the faith-based organizations.
That's interesting. So now, in addition to providing information and giving people a place to learn and ask questions, the faith community may also be an important source of support when families do encounter RSV. What does that look like?
Well, you know, again, within the faith-based organization, you're going to have a very intergenerational group there. So many times you may have the mother, the daughter, the grandmother, aunts, and, you know, just a wide variety of support system within the family. So those individuals can not only maybe give the mother some relief if they have more than one child, but maybe if they need someone to run to the grocery store for them or to do other family chores. The faith-based organization can step in and provide that ground level support for the individual so that the mother can also have some rest time and free time.
Right. Well, thank you, Dr. Dawson. This conversation was an important reminder that healthcare doesn't just begin and end at the doctor's office or the hospital, but really is a community-wide effort, especially when it comes to a virus as prevalent and potentially dangerous as RSV. So thank you for joining us. And now I'll turn it over again to my colleague, Susan Hepworth.
Thanks, Amanda. I am very excited to introduce today's keynote speaker, Representative Nanette Diaz-Barragan. Representative Barragan represents the 44th District of California, located in the Los Angeles area. She was first elected to Congress in 2016. Representative Barragan earned a BA in Political Science from UCLA in 2000, and then went on to earn a Juris Doctor from the USC Gold School of Law in 2005. She is Vice Chair of the Congressional Hispanic Caucus and is a member of the Progressive Caucus. She serves on the House Committee on Homeland Security, where she chairs the Subcommittee on Border Security, Facilitation, and Operations. She also serves on the exclusive House Committee on Energy and Commerce and is only the second Latina in history to ever serve on this committee. Legislatively, Representative Barragan focuses on the environment, healthcare, and immigration, always with a racial equity and social justice lens. Representative Barragan recently sponsored the task force recommending improvements for unaddressed mental, perinatal, and postpartum health for New Moms Act of 2021, or the Triumph for New Moms Act of 2021, which we will learn more about today. We hope to have time for a few questions at the end, so please submit those at any time using the Q&A box just under the live stream. Representative Barragan, welcome, and thank you for joining us.
Well, thank you for having me, Susan.
Representative Barragan, the full name of this legislation is a bit of a mouthful, but can you share more with us about the Triumph for New Moms Act of 2021?
Well, thank you for that question, and thank you for having me. It's good to be with the community of advocates for infant health. The Triumph for New Moms Act is a bipartisan bill that creates a federal task force across multiple federal agencies and representatives of medical societies and nonprofits with expertise in maternal or mental health. Now, the task force would be chaired by the Assistant Secretary of Health and Human Services. The goal of the task force would be to improve our health prevention and care network for new moms so we can reduce the disparities faced by new mothers of color, support effective policymaking on maternal mental health, improve federal, state, tribal, and community partnerships on addressing maternal mental health, and improve workforce guidance to create supportive work environments for expectant mothers and mothers returning to work. Now, the task force would take 3 important actions for improving maternal mental health. The first is to review and identify existing programs and best practices in our federal agencies and at the state and local level to support maternal mental health. The second is responsible, it's going to be the responsibility of the task force to make recommendations to close gaps, eliminate duplication, and coordinate federal resources around improving maternal mental health. The third is to create a national strategy for maternal mental health and issue recommendations to enhance federal, tribal, state, and community partnerships so that we have new actions being taken at all levels of government. And I want to also note that the task force will be regularly updating and doing a review of their report. So we have a national strategy, so it's up to date, and that we're hearing across the board. And so, I'm proud that this legislation is also bipartisan, introduced by not just Democrats, but Republicans. And this is an issue that is not partisan. And so just want to give a shout out to some of my colleagues on both sides of the aisle, Larry Bouchon and Lisa Blunt Rochester, along with Young Kim, who all stepped up when I approached them on this issue.
And you're absolutely right, Representative. It is a completely bipartisan issue. And so we're glad to see that there was support on both sides. I'm curious what made you want to introduce this bill. I mean, was there a particular compelling piece of data that you heard about? Was there a compelling story that you heard from a constituent that made you think this needs to be addressed at the highest level of our government?
Well, first, my sister is a nurse and works at a hospital helping deliver babies. And I think I first started hearing about the issues of maternal mental health through stories that she would share with me and the follow-up she would do with new mothers when she saw how they were doing days after they went home. But I also then looked at the statistics and I decided to introduce this bill because it's really unacceptable that 1 in 5 women and 3 in 5 women of color will suffer from maternal mental health a condition. So there's so much that we can do, but we have a lack of federal coordination and strategy around maternal mental health. And half of these women never receive treatment. It is tragic that suicide and overdose are the leading causes of death for new mothers. And again, I just think we can do more. In addition, untreated maternal mental health disorders can impair mother-child interactions, negatively impacting the health of the infant. So in communities of color, this is disproportionately affecting the mental and the physical well-being of women and their children. I mean, think about all of the stressors these new mothers of color, their partners, and their children often face, whether it's poor access to affordable health care, a lack of child care, underserved schools, a lack of healthy food options, and polluted environments with high asthma rates. So the impact of mental health disorder like postpartum depression or anxiety is compounded by all of these inequities. And we know we can do something about it. And it's time that we use an all of government approach and plan to hone in on best practices out there to increase screening to detect these disorders and coordinate federal resources to improve treatment and access to treatment as well. So I think that this piece of legislation can help us move in that direction to get there.
Absolutely. So we know that during COVID, many women experienced the birth of their child without a partner or family member present due to some restrictions on who could come into hospitals. We just finished talking about that a few minutes ago. And that can really affect one's mental health. In fact, Marissa, our previous guest, talked about, what a challenging experience that was for her. And if she had not had the support of her husband with her, that she believes she would have been at greater risk for postpartum depression, and all those emotions that she was feeling having a hospitalized baby could have been, to the point of overwhelming for her. So, and more broadly, we also know that parents of infants who spend time in the NICU experience postpartum depression and post-traumatic stress disorder at much higher rates. And we know that prematurity disproportionately affects minority communities. So we have compounding disparities. I'm curious if there was any correlation between the introduction of this bill to what was happening with COVID, because I do think coming out of COVID, we will perhaps see that there has been an even greater uptick in these mental health disorders.
Well, you're right in that COVID really highlighted, number one, the disparities that we have across different groups, but we saw this increase in mental health issues and concerns, and we saw it in the maternity wards, and we saw it in hospitals, and I certainly heard about that. So while it wasn't specifically in response to that, the COVID situation did highlight the need for us to really invest in maternal mental health and mental health so that we have provided resources and we give resources and that we collect these strategies across the board and we share them and have the federal government involved in that. So there's no doubt that COVID has been difficult for pregnancy and delivery, and as a result has really impacted maternal mental health. So of all the stressors and challenges facing women of color that I just talked about, COVID really heightens them all. It's no different with maternal mental health. And as pandemic showed us, social isolation makes it harder. And when you're going through an experience like having a child, there's other emotions that women feel, and it's so important to have that ability to have that support system. And I did hear stories from fathers who said they couldn't be in the delivery room, and it really depended on what part of the country you were in, on people's experiences. Because social distancing did mean that partners couldn't accompany pregnant women to important doctor appointments, sometimes even delivery. In some cases, women have been giving birth without partners because of the hospital safety rules And, we have to also recognize there was a period where when there was no vaccination, and then there was a vaccination, and those changes. So I'm glad to hear, your previous speaker's experience on this, and how hard it has been on women and families on it. So I am proud that this bill will maybe help us address some of those issues.
Yeah, and it definitely has been a roller coaster, as you've mentioned. So, okay, watching today, you've got hundreds of advocates, you got other policymakers, you've got clinicians, you've got parents and families. So this is your opportunity, I guess, to let us know, what are the next steps for the bill, and what can we do to help you get this through Congress? Because I know this is an issue that's extremely important to this community. So you've got everybody listening right now. So here you can tell us what you need help with.
Well, thank you. The way Congress functions is, public sentiment moves the needle, and it's very important for Congress to hear about the support, especially those who are participating today, right? You are the clinicians, those on the ground that deal day in and day out with this. And so expressing support on legislation like this and how it could be helpful will help advance this legislation. So the first thing we have to do is we have to get a committee hearing in the Energy and Commerce Healthcare Subcommittee on the bill. It's a subcommittee I sit on, so we're working hard internally to do that. But when we do hear from outside groups and those experts, it also helps. Before a bill can receive a vote in committee and move to the House floor, most bills need to have a legislative hearing in the committee, and that's why that's the first step. Now, two important ways we can build support for committee is also to continue to add co-sponsors to the bill. So if you're having meetings with other members of Congress, it's showing support for the bill, asking the member to look at the bill, to consider signing on to it. The more co-sponsors that we have, the better, and to broaden the coalition of groups and support. Right? It doesn't have to just be those in the field that support this, could be others. And so building that support is important on a bipartisan basis. And the more we can get a bipartisan support, the better it is. So outreach, and showing support is good. I'm just going to remind people of the bill number. It's HR 4217. It's 4217. And, if your organization or individuals want to do an event around it, or help educate others about it, contact our office, and we're happy to get that set up, because we want to make sure we're getting this across the finish line.
Great. And just so our audience knows, we have pasted into the pasted into the chat box a link where you can learn more about that bill there. And we will be sure, the coalition to push out any sort of information to help move this across the finish line. So Representative Barragan, I think we have time for a few questions, and I've gotten a couple of in here. So one person asked, what is the bill's name again? I'll give them the short version. It's the Triumph for New Moms Act of 2021. The whole bill name is a little bit long there. And then some people are asking, one of the issues that we see as it relates to postpartum depression is the stigma that goes along with it. How can we educate the public and reduce that stigma?
Well, I think that's an ongoing effort we need to do on mental health issues in general, that it's okay not to be okay, right? And we have seen examples where we've had, some very high-profile athletes help make the statement that it's okay to not be okay. And we have to be accepting, but we also have to reach out to communities and let them know. I'll give you an example. Like in my culture and community, in the Latino community, we never talked about it. We never really knew about, if you didn't feel okay, that you could go and talk to somebody about it. And oftentimes people were led to believe, that if you did that you weren't strong enough. And so those are the things that we really need to dispel, because we need to make sure that people feel, that safety and security. And that's one of the things I'm hoping the task force, when they're looking into this, is preventive measures, and what can we do to do more outreach, and what can we do to try to prevent it from getting to the point where you're already experiencing, these the mental health issues, and if you are, that you feel that safety and security of saying, I'm going to talk to somebody, I'm going to get the resources I need. And oftentimes people don't know where to get the resources or to who to call. And I think that's one of the things we're hoping to identify in the report is what are the tools out there? How can we help with this? And my hope is that this task force will help us address those and help us educate folks out there.
Great. A couple more questions, and this is an interesting one. This person says, as a new mom, sometimes I don't feel qualified to get in touch with my representatives. Will they even take my call?
Well, absolutely. And let me tell you, the most important call that any member of Congress gets into their congressional office is a constituent. It doesn't matter what your title is. It doesn't matter what you do for a living. What matters is you're a constituent, and it's our job not only to listen, but to take feedback and to consider it. And so when I have meetings with constituents or people call my office for a meeting, constituents are top priority for me. And I know that of many of my colleagues. So don't be shy. Please do reach out to your members of Congress, share your stories. And I got to tell you, personal stories are moving and compelling, and they help us be better advocates on the issue when we know your story, especially if you're willing to let us share that story at a congressional hearing. We hear stories. I've been in a congressional hearing, and I've heard the story of one of my colleagues' constituents, and that will move me into saying, oh my goodness, I didn't realize, this experience or that somebody had to go through this, and it's really compelling. So please pick up the phone, feel free to reach out to your members' offices and ask for a meeting with a member. If it's my office, we take constituent meetings. I personally will do them. And sometimes if the member is too busy, staff will take that, and everything that you convey to staff is conveyed to the member. So please do not hesitate. And if you want to pen an op-ed, to share your story and how piece of legislation would help, those are all very helpful.
And I would concur with you there that sharing the personal stories is incredibly compelling. Of course, data is important too and can illustrate certain points, but it's really the personal stories. I always give the example of a President of the United States State of the Union address is usually not full of statistics. It's usually full of stories, because that is how they move the needle and that's how they push forward their legislative agenda. So I think we just have one more question here and then we'll wrap it up. This person says, I appreciated hearing you touch on mental health some. It's a huge issue in my community. What kind of mental health support should I be pushing for from my local representatives?
Well, the first thing is that there is not a big enough advocacy group or lobby on Capitol Hill to move the needle on mental health. And that's why we all need to step up to share our stories and continue to push our elected representatives to invest in mental health resources. I'll tell you a story of just this year where somebody said, I'm having a really difficult time. I want to talk to somebody. Where do I go? And the response the person received was, well, I don't really know where to send you because there's such a great demand for mental health right now that I don't even know where I can find a provider. And can you just imagine that response? It's unacceptable. And we really need to change the system so that everybody has access to mental health resources and services, regardless if you have health insurance or not, which is a whole nother issue. But just continuing to, I think, advocate to make sure that we are including resources and dollars because dollars matter in outreach and education and making services are available, but continuing to also fight to expand access to healthcare, which should include mental health services. I can't tell you how many times I hear the story that I have health insurance, but I can't see a mental health professional because it won't take my insurance. I can't pay for it out of pocket, which is what I'm being asked to do, and then I'll get reimbursed later. In my congressional district, that is economically disadvantaged, people cannot afford to pay those costs up front. And so we still have this huge barrier in addition to the stigma. So continue to just, I think, advocate for funding resources and access to healthcare that has good mental health resources and treatment available.
That's right, and I think one of the key elements too of this national strategy is just going to simply be elevating the awareness of postpartum depression and its impact not only on the mother but on the baby and then the family as well. And that's one of the reasons that we wanted to bring you here today to talk about this. So Representative Barragan, thank you so much for joining us today, and thank you for being a voice in Congress that cares about the health of our new mothers.
Thank you for having me. Appreciate it.
Thanks. For our next Viewpoint segment, I sat down with Liliana Miramontes, a Hispanic perinatal nurse in Southern California. Liliana has a passion for ensuring that the nursing workforce is representative of the patients they serve. Here's my conversation with Liliana.
Thank you, Liliana, for joining us today and for sharing your perspectives as a Hispanic nurse. So we're going to get right to it. I first want to ask you, you've spent your whole nursing career working in an area of the country that has a very large Hispanic population. In fact, one of the largest in the entire country. You practice in the Los Angeles area. But even still, you yourself have experienced biases and negative experiences because you are Hispanic. And you've also seen patients that you work with experience those biases who are also Hispanic. So I'm wondering if you can just start out by maybe sharing a couple of examples of when you have been on the receiving end of those biases.
I think a lot of the biases come from the patients themselves because they view me as someone who might not have the same educational background, let's say, as a physician. So I experience a lot of biases from patients where when I give them explanation and education and explanation of their care, they don't seem to want to believe or to accredit me for giving them all that. And so they sometimes would ask for the physician, and basically the physician would come in and repeat everything that I educated the patient on. And it kind of like, it puts me in a position where I feel that the patients don't credit me as the way they should, just because I'm a Hispanic nurse. So that's a lot of complications, or a lot of biases that I've experienced. Also too in the medical field where, being promoted or having a administration where you see Hispanic nurses in it, you don't see very much. So I think being able to have more Hispanic nurses in the administrative roles is where we need to go to as well, being able to combat biases in that area as well.
Yeah, and Liliana, we're going to get to that actually in a few more minutes. I'm going to ask you a little bit further about the need for diversity and inclusion among healthcare providers. But the second thing I wanted to ask you is, you are a Hispanic woman yourself and a nurse. So can you just give us a little bit of education for people who may not understand some of the nuances of the Hispanic culture that impact how these women and families experience birth and pregnancy? So I'm wondering if you can just kind of share a little bit about some of those nuances.
So a lot of the Hispanic population are English as a second language. So their native language might be Spanish, and they might not have the same educational background as American citizens might have. So their level of education might not be the same as what you experience. So being able to educate those patients is where we really need to focus on, because they come very clueless in the hospital setting. So being able for them to understand what is American medicine and to what is the whole process of the labor and delivery, that's where the focus is. And that's where we're failing this patient population, because they don't understand. And yet they don't have any resources where they can understand in the language that they have and the educational level that they have, and being able to understand the process. So a lot of times they actually look forward, they get information from their families and what their families experience. So they look towards their families, the family cultural, and being able to understand what their mothers or their grandmothers experience. But then again, not every woman has the same experience as what their mothers did or what their grandmothers did. So I believe that is the barriers that I'm dealing with when dealing with the Hispanic Latino community, because there's not a lot of education in the level that they can understand.
Yeah, so it's not only the level at which they understand it, but it's also just simply the language in which they would be able to understand something like that. So it sounds like perhaps a need for more resources in the Spanish language. That way they can look towards some of the more like reliable, I guess, scientific resources out there, and not necessarily just a family member's experience that, you know, as you mentioned, could have been in a different country with an entirely different healthcare system. And the way they experience childbirth may be very, very different from how someone experiences childbirth here in the United States. So the last thing I want to ask you about is just something kind of personal to you. So you're going to be entering the midwifery program at the University of California at San Francisco very soon. In fact, just a couple of days, I think. And that's really awesome and excellent. But you told me that one of the reasons you're doing that is because not only that you just want to further your education, but you want to make sure that there is diverse representation among healthcare providers, and especially in the midwifery area. So I would just sort of like to hear a little bit more from you on why you chose to go into midwifery and what are you looking forward to, I guess, accomplish by doing so?
I feel very I'm trying to figure out the word, but I feel very, very honored to be in midwifery, into perinatal, because I think in my field of nursing, for in general, we are a happy unit. We're a happy area where, you know, people are celebrating the birth of a new child. We don't deal so much with illness and death and dying, but we do deal with a lot of like bringing a new life into the new world. And to see that and to be able to be part of that family's experience is really rewarding. So I feel that my field of nursing is a rewarding area, and I always wanted to feel that there needs to be more representation of Hispanic nurses, because people want to see themselves in you. So they want to see representation. They feel comfortable. Somebody who understands their culture, somebody who understands their language, somebody who can communicate everything, because they put their trust into you. So that's one of the reasons why I went into midwifery, and just because I really love what I do. I feel that there is very much a need, especially in rural communities and areas where there is not a lot of representation, and so they look for that. So there needs to be more people who understand what it's like to be a Hispanic woman or a Latino woman in the United States, and to be able to find a healthcare system where they could turn to, where they feel comfortable, where they know that there's somebody who understands their background, their culture, their understanding of what they want. So I feel that there is definitely a need. That's why I went into it.
Well, that's awesome. And I can tell that you're passionate about it and that you love what you do. So, Liliana, thank you so much for joining us. Thank you for sharing your perspectives as a Hispanic nurse and a Hispanic woman. And we wish you the best of luck as you enter your midwifery program.
Thank you so much. Have a good one.
Bye-bye.
We are grateful to Liliana and wish her the best as she continues her education to become a midwife. For our next segment, From Mom to Baby, Antibodies and Rare Diseases, we're going to learn that some maternal antibodies carry risks that pregnant women should understand. Though serious dangers are rare, expectant mothers should be aware of them and prepared to discuss them with their doctors and providers as part of their prenatal care. But before I introduce our guests, here's a new video from the Coalition on this topic.
From prenatal vitamins to maternal vaccines, expectant moms want the best for their unborn babies. But sometimes what mothers pass on to their babies can, through no fault of their own, cause serious health issues. This can be the case with antibodies, which are proteins produced by the immune system to help the body fight bacteria and viruses. One example is a rare blood disorder that causes mom's antibodies to destroy the baby's red blood cells. It's called hemolytic disease of the fetus and newborn, which can cause severe anemia and jaundice. The disease can occur when the pregnant mother's blood and her baby's blood are incompatible with each other. Another example is when a baby's blood platelets are not compatible with the mother's. When this happens, mom's immune system may respond to her baby's unfamiliar platelets as if they were attacking her, sending harmful antibodies across the placenta and causing fetal neonatal alloimmune thrombocytopenia, or extremely low platelet counts in her baby. Sometimes, harmful antibodies transferred to unborn babies have nothing to do with compatibility, but instead result from their mother's own immune system. This is the case with congenital heart block. If the mother has an autoimmune condition, such as lupus or Sjogren's syndrome, her body may create antibodies that attack her child's heart as it develops in the womb. The good news is that these conditions are rare, and new, innovative therapies are being developed that could be life-saving for babies. Meanwhile, expectant mothers can take proactive steps to reduce their baby's risk. Women can consult with their obstetric care provider about testing to identify potential blood type incompatibilities and other risk factors. All mothers want what's best for their babies. Through greater awareness, heightened vigilance, and improved testing and treatment options, babies have a better chance of healthy growth and development before birth and a healthy childhood. Learn more at infanthealth.org.
I am pleased to welcome Dr. Kenneth Moise and Suzanne Shores. Dr. Moise is a professor of women's health at Dell Medical School and is the director of the Comprehensive Fetal Care Center at Dell Children's Hospital. Suzanne is a certified nurse midwife and family nurse practitioner, and she currently works at UPMC Magee Women's Hospital in Pittsburgh, Pennsylvania. So thank you both for joining us.
Thank you.
Before we begin, I actually want to ask the audience a question. So if everybody is on the live stream page, you'll go ahead and see this question pop up for you, and then I'll be able to get the answers here. So I'm going to read this true or false statement, and here it is. True or false? Fully COVID-19 vaccinated women can pass IgG and IgA antibodies against SARS-CoV-2 through breast milk to their babies. So it's a true or false question. And I'll be able to look here on my little tablet and see. We'll give it just a few seconds for the results to come in. But once again, it looks like we have a pretty smart audience. 90% say that that is true. So Suzanne, is that true or false? And then I want you to just tell us generally a little more about what antibodies are, how they benefit babies.
Sure, yes, that is very true, and some exciting data that has come out recently with all of the research that's being done around the COVID vaccine. And great question, what is an antibody? And the video prior to us coming on did a really great job of explaining that. But if we think about our body's immune system as an army, we kind of have two battalions. One battalion are the seekers and the others are the destroyers. And so in this army, our antibodies are the seekers. They are those, as you saw in the video, Y-shaped proteins, and they seek out the invaders in our system that may cause us harm, as in viruses and bacteria. And that special shape allows them to connect and bond to the invader in our system and send out a signal for our immune system to send in the destroyers and kind of take care of that and banish it. The really, how we get those is by exposure. Our body builds antibodies by being exposed to a previous illness or by having a vaccine. And the really amazing thing and great things about pregnancy is a person who is pregnant and or lactating can pass those protective antibodies to their baby because the baby's immune system is immature and lacks that exposure from an acquired sense. So while they're in utero, those antibodies can actually pass through the placenta and give babies protection after they're born. A great example of that is the Tdap vaccine, which we recommend for women to get in the latter parts of pregnancy to help prevent, to help build up the antibodies for pertussis that can help prevent infection and protect the baby after they're born before they receive their vaccine. And newly, just like our poll question indicated, is that we now know that women or pregnant people who have been vaccinated or persons who are lactating and sharing breast milk with their neonates, if they have been fully vaccinated against COVID, we are finding that there are both the IgA and the IgM antibodies in breast milk that also help pass to the baby and help protect them as well.
Okay, so Dr. Moise, I want to ask you, Suzanne just talked to us, a little bit of background, some primer on what antibodies are, but not all antibodies are necessarily good, and in fact, they can cause the baby harm. So can you share a few examples with us and explain to us why some are good and then why others are not as good?
Well, as we saw in the video, antibodies are proteins that can pass through the placenta, and in many cases, as we just heard, the antibodies are beneficial to the baby and they give the baby protection after it's born. In the process of antibodies crossing, you can sometimes produce, if you would, bad antibodies. Antibodies that actually cross the placenta and attack various components inside the baby. The most common of these is antibodies to red cells, such as the Rh antigen on the red cell. Antigens are proteins on the cells. And if a mother and baby have incompatible blood types and she develops antibodies, typically anti-D, that antibody can cross through the placenta, attach to the baby's cells, and cause a disease called hemolytic disease of the fetus and newborn. That is, the baby can become extremely anemic even prior to birth and can develop jaundice after birth. And so there can be bad antibodies, if you would, that sometimes are created. These are typically IgG antibodies that cross and can have some deleterious effects on the fetus. The good news is most of these antibodies to red cell problems can be prevented by an injection called RhoGAM that prevents women from forming anti-D in about 98% of cases during pregnancy. There are other red cell antibodies, such as anti-little c and anti-cal, that we don't have preventative measures for that still can occur in some cases. But Suzanne, maybe we could ask the next poll question, and maybe our audience learned this from the video, but can they think of other examples of types of conditions in babies that could be caused by harmful antibodies crossing the placenta?
Yeah, so that's a good idea. So let's move into that poll question. And this one is a little bit more clinical, so maybe not everyone who's watching today will be able to participate it, but I know for a lot of our clinicians they will. So here's the question, you'll see that appear on your screen down there. What is the second most common fetal disease after hemolytic disease of the fetus newborn that is the result of transplacental transfer of pathogenic maternal antibodies? So we've got four choices. A, is it congenital heart block? B, fetal neonatal alloimmune thrombocytopenia? C, gestational alloimmune liver disease? Or is it D, immune thrombocytopenia purpura? And we will take a look at the results here. And if anybody wants a little bit of a hint, we did talk about it in the video before this segment. So it was mentioned in that video. So we'll give it just a few more seconds to see. And once again, we have a very smart audience. They chose the correct answer. Over 50% said B, fetal neonatal alloimmune thrombocytopenia. So that's good news. So Suzanne, you are a certified nurse midwife. What happens, I kind of want to move from what is this disease to now how is it that we look for it? You know, what are some of the signs and symptoms? So I'm curious, when you see a patient and you suspect she may have one of these rare diseases, what exactly is it that you're looking for to know that she might have this?
Sure. I think one of the hallmarks of midwifery is assessing risks, and that's something that we do throughout the pregnancy. And as the video alluded to, there are some screening tests. In the instance of a hemolytic disease, it's very simple as screening a woman's blood type and finding out what their blood type is and determining if they have any of these antibodies that could potentially cause harm. In later forms of disease, some of these symptoms or side effects can show up as effects that can be seen on ultrasound. So as a nurse midwife, this is not something that I would treat independently, but it is my job to recognize when something is no longer moving forward in a typical pattern and could be a risk or a complication with the pregnancy. And that's why we rely so heavily on our collaborative relationships with our generalist OBGYNs, and specifically in rare disease with our specialists, our maternal fetal medicine specialists. And our role there is really educating the patient and getting them into a consultation or referral to a higher level of care with a maternal fetal medicine specialist in order to be able to treat this disease.
So I want to stay on the topic of midwifery. So we know that the important role that midwives play in the diagnosis, and then of course, kind of seeing them through the treatment of these rare conditions. But I just would like to hear from you, more specifically maybe about, midwives can sometimes practice in rural areas where there may be lack of access to these, maternal fetal medicine specialists. So I'm curious to hear your thoughts just a little bit more generally about really the role that midwives can play in the diagnosis and treatment of these conditions.
Yeah, absolutely. So because we're in a period of time where we have a shortage in our healthcare providers, and specifically in our OBGYN generalist providers, we do see advanced practice nurses and midwives practicing in more rural areas and providing routine prenatal care, attending the birth, and caring for women after delivery. So the role of the midwife in these situations is to do that ongoing health risk assessment, educating women about what to look for in their pregnancy that could be concerning, and then facilitating the transfer or referral. And in these cases when women are at distance, they might be in a rural area, a midwife would often be the person to continue the routine prenatal care, and then the higher order or higher risk care is provided by a maternal fetal medicine specialist who might be in another city. Those might be done via telemedicine, or it might involve the patient having to travel to another area to see the specialist, or birth in a facility that has a higher level of care for the neonate after it's born. But the role of the midwife really remains the same in being the primary care provider in a lot of instances, doing that ongoing risk assessment, really educating the family and the person who is pregnant, and in order to prevent potential disease, but also to catch it early, so early detection and early referral.
Yes, and definitely that collaborative relationship that you talked about earlier between the OB provider, the specialist, and the midwife is really important. Dr. Moise, I want to go to you next. So what is the current treatment processes for diseases like hemolytic disease of the fetus newborn, or some of these others that we've talked about? And how is it that we can help promote innovation for these moms and these babies who deal with these sometimes life-threatening conditions?
Yeah, that's a great question. So currently for HDFN, or hemolytic disease of the fetus and newborn, we're left with putting compatible blood into the baby in the form of an intrauterine transfusion to put cells in the baby that won't be attacked by the mother's antibodies. And unfortunately, when we have to do that, we do it multiple times, like every few weeks. An average pregnancy will need at least 4 transfusions during the pregnancy. These are have some risk to each procedure. In experienced hands, the survival rate for these babies can be in excess of 95%, but it's not 100%. And if we have to do these early in the pregnancy, say before 20 weeks gestation, that's halfway through the pregnancy, the survival rate can be about 80%. So they're not perfect, but they're really all we currently have to treat these pregnancies with this severe disease. For some of the other diseases like FNAIT, where there's a platelet problem, we try to manipulate the immune system with sort of shotgun therapy with oral steroids, or something called intravenous immune globulin, which is quite expensive and has some complications and requires infusions every week. And that can be quite cumbersome for the patient to get that infusion once or twice a week. We don't have good treatments for congenital heart block currently. We're sort of at a loss as to how to predict that and how to treat it. The good news is on the horizon, there are several companies looking at ways to sort of combat the immune system, if you would. And in the world now, what we call monoclonal antibodies, these are engineered antibodies to specific targets, Janssen Pharmaceuticals is even working on an antibody to block what we call the FC receptor of the placenta. So this would stop the transfer of antibodies across the maternal placenta and in essence block the bad antibodies from crossing to the baby. And it's currently being looked at in a phase 2 trial in hemolytic disease with a newborn in moms who've lost babies previously from this severe disease. But it has promise, based on its mechanism of action, to be useful in other diseases that involve antibodies as well. So we have a long way to go in that research before we know this is a safe and effective method, but the day may come where we have effective treatments for the mother to prevent these antibodies from crossing the placenta and causing damage to her fetus. So we're in an exciting time where we're beginning to see science make a big impact on these pregnancies, and I look forward to that future.
Yeah, Dr. Moise, I want to follow up on that point. So earlier today, we had a discussion about the need for innovation and safety for the neonatal population because they are not tiny adults. And so there's a lot of these things on the horizon. And so I guess I'm just kind of curious to ask you, it sounds to me like maybe, you know, blood transfusions are not the most ideal way to be treating these babies. I mean, I know it's what the option is right now. But what would it mean to have new therapies and devices come to market that could increase survival and kind of put to the side some of these less ideal ways to treat babies?
Yeah, so one of the problems we're running into now, as I mentioned earlier, we have an effective treatment called ROGAM to prevent some of these diseases, not all of them, so that there are fewer cases that need treatment. And as a result of that, there are fewer physicians who are experienced in these methods. So sometimes patients have to travel to distant fetal centers, like ours here in Austin, to get that kind of treatment from experienced physicians. There are fewer of us around, and some of us will retire at some point. So having innovation that could treat these diseases medically at any institution would be a benefit to the patients, both from better outcomes, because you wouldn't need the experience of technicians to do these procedures, and you could get it at your local hospital under certain protocols. And so the innovation would be allowing patients to not travel as far for treatment and to have better outcomes in general.
Great, great. Well, we have time for just a couple of questions from our audience, and I've gotten a couple of them in already, so I want to ask you. And I maybe will ask Suzanne this question. Sorry, I just lost my question here. I think they said, is there a timeline on how long antibodies last in a baby after they are born?
Yeah, that's a really great question. Antibodies can last for up to 6 months in a baby afterwards, but it's not a replacement for childhood vaccinations. So those, the same way that adults can have waning immunity to certain diseases like the chickenpox or varicella, the same thing. Those, the further away the baby is from exposure, the chance that that immunity could fall and the baby is not as protected, but it could last for up to 6 months.
Okay. And then
I don't know that
Moise,
we have the answers to that where COVID is concerned, though. We're still working on that one.
Oh, okay. Yep, still collecting the data on that. Dr. Moise, I'm going to ask you this question, and then this will be our last one for the day. What advice would you have to someone considering getting the vaccine if they are pregnant? Would you recommend it? Would you not? The COVID vaccine.
So in a perfect world, I would say to get one of the mRNA vaccines prior to pregnancy. The data on infertility related to these vaccines supports no effect on fertility. We do advise that young women not get the J&J vaccine right now because there's more concerns about blood clots in young women who use J&J as their vaccination technique as compared to the mRNA vaccines, Moderna or Pfizer. I think pre-pregnancy makes the most sense. Even in pregnancy, at any point in pregnancy, getting a COVID vaccine makes a lot of sense. Not only to protect the mom, because we know women who get COVID in pregnancy have much higher complication rates. They seem to be sicker. They develop more lung problems, end up in the ICU. more, end up on ventilators more. But also, as we've already been talking about, that vaccine is going to protect their newborns when they're born. And so, and if they breastfeed, that protection will continue for some time while they're breastfeeding. So I would say that almost any time in pregnancy, and that's a recommendation of the American College of OBGYN, the Society for Maternal Fetal Medicine, and more recently, the Centers for Disease Control have all gotten on board and said women who are pregnant are high risk and should be vaccinated COVID. No question about it. I talk to every one of my patients every time I see them, and I advise that at every prenatal visit if they're not vaccinated.
Great. Well, thank you for that. Well, Suzanne and Dr. Moise, thank you so much for joining us today. Thank you for talking to us about these rare diseases and the signs and symptoms to look for, and also potentially the new innovations that will be able to help this population. So thank you for joining us.
Thank you.
Thanks for having us.
For our fourth and final viewpoint segment today, I am joined by Gigi Konyangwa Fernandez, who will share with us her perspective as a Black woman and how we can assure every family and every baby receives optimal care. Gigi is a preemie mom who spent 6 months in the NICU. She is also a former healthcare provider with experience in both the U.S. and the UK, and she is a strong advocate for NICU families. Gigi, thanks for joining us all the way from England.
Hello, everyone. Hi, Susan. Thank you for having me.
Thanks for being here, Gigi. So as a Black woman who has spent a lot of time in the NICU as a preemie mom and in hospital settings as a provider, I want you to share with us a couple of examples of experiences that you've had, experiences that you've witnessed with other people that really showed what these biases are, whether they are conscious or unconscious.
Yes. Unfortunately, Susan, I've experienced many, like many people who are part of underrepresented groups. But for today, I think I would just quickly share and summarize two that come to mind. As a NICU mom, my son, who was a surviving twin, was born at 24 weeks. And like you said, we spent 6 months in the NICU. So we were there a long time. We got to know quite a few people. But I was ignored, basically not spoken to at all, for many weeks by one of the senior neonatologists there until my son developed NIC. And after his operation, and he was a little bit more stable, voila, he was immediately deemed an appropriate or eligible sort of candidate for this clinician's research study on nutrition. And suddenly I was seen by this doctor, and she would approach me daily to just ask me to enroll my son in her study. And I said that I would consider participating in the study. She assumed this meant yes and expected me to immediately consent, agree, sign my name, etc. And I think this is a common occurrence for Black NICU parents, that we're often not heard even when we speak. And I think just as a clinician, I'm an occupational therapist by background, and my specialty is neurology. And like you said, I've worked in various, acute centers, rehab centers, acute hospitals, et cetera, both in the US and the UK. And I just, one example that comes to mind, I think I shared this with you, Susan, when we spoke earlier. I just started work as a therapy manager in a rehab hospital in a state I won't name. And I was walking down the corridor to a meeting, and so I was walking, and I heard from behind me, I heard someone screaming, just sort of shouting, hey, and in a very aggressive tone, very derogatory tone. And I didn't, I just kept walking. I was, new to the place, to the center. And maybe about 30 seconds later, I felt someone, sort of a hand on my shoulder, and turned, like I was sort of pushed around and facing this woman. And she was just beginning to shout. And then she saw my name and saw that, my title. And she said, you're a therapy manager. And I said, yes. And she says, I thought you were the housekeeper. And I paused and counted for about 20,000 seconds and said, why did you think that? She knew why, I knew why, but I just let the silence kind of stay there for a minute. And I just, began to say, that it's not appropriate, whether I was a housekeeper or not, it's not appropriate to speak to people like that. And the day went on. She didn't apologize, and I ended up going to my meeting, and lo and behold, she came in the meeting about 5 minutes later, saw me, turned red face, and didn't say anything. But I think unfortunately, those type of examples, when you are a Black person in the U.S. or anywhere, it happens so often, unfortunately, that you almost sort of prepare yourself for it. Even if you're not looking for it, you sort of prepare yourself for them to occur.
Mm-hmm. So that's really interesting, Gigi. So in some conversations that you and I have had, and you just kind of touched on it here, you've talked about fighting assumptions. Those are the words you used with me. And what that's like for families in the NICU or maybe in the PICU or any other clinical setting.
Yes.
But these are people who right off the bat are fighting against stereotypes. And I want to know from your perspective how that impacts a family's experience and how it might actually impact the baby as well.
It's a really good question. I think it hugely, hugely impacts our experience because truth is seen as a lie and lie is seen as truth. And by that, I mean that as a Black woman, I am immediately is an assumption that I'm uneducated, I'm inarticulate, I'm hostile, or I'm less capable of caring for my child. The number of times that I've heard that people have told me in my face, "Oh, wow, you're articulate." And I was like, well, why wouldn't I be? But those are things that happen so often. So when I show up and I don't fit into those little boxes, it becomes disconcerting, not for me, but for them. And so what happens is people actively try to put you, or shall I say force you, into this little tiny box that you just don't fit. And what it does is it causes, I feel, it causes unnecessary trauma that you have to deal with when you're already being traumatized just by being in the NICU. I mean, we all know that being in a NICU is a surreal and abnormal place to be, no matter how we try to normalize it. You're surrounded by death, life and death, every single second of the day. And so you're having to exert additional energy that you should be exerting on your, spending with your child on dealing with lots of ignorant assumptions. And that's quite exhausting. And also, I think what it does for your child is that you are, there's a huge level of mistrust. And so you're not quite sure what the clinicians are doing and whether they're going to do it or treat your child in the most appropriate way. And really, you shouldn't feel that way. You should be in a space of a caring environment. You should be in a very trust-filled environment. But sometimes you feel like you're on edge. And so it really impacts your ability to go into the space, really focus on your child during that time. You're in a very fragile space. Really put energy onto them. And that should be your only focus. It should really be your only focus. It shouldn't be what is that nurse or doctor or researcher is going to say or do. And I think for us, I mean, I was just going to say really quickly, we had an additional assumption kind of put on us because I was, American, but I was living in the UK. My husband was from Spain, and so we again didn't fit this picture. And oftentimes we were not considered a couple, and so either he was ignored or I was ignored because people were not assuming that we were together.
It's very interesting you bring that up, Gigi. So someone that we spoke to earlier from the LGBTQ community was just talking about the importance of recognizing that just because someone's family may not look like your family doesn't mean that they should be treated any different. And we shouldn't go in with those assumptions that a family looks a certain way, because in fact, it may look very different from that. So that's just what you were speaking about there. So I want to ask you just lastly, from your own professional and personal experience, how is it that we create a sustained mental shift in both the current generation of healthcare providers, but also future generations, to ensure that every single baby and every single family, regardless of how they look, receives optimal care?
Keep the conversation going. I think it's so crucial that conversations happen. These are, and I mentioned to you, Susan, earlier that we have to get comfortable with being uncomfortable. And so we really have to keep these conversations happening. And discriminatory practices and attitudes and behaviors, and I saw them even as a clinician, working in sort of the information that was provided to one type of patient was not provided to someone else. And there was no sort of logical explanation as to why this was occurring, other than the fact that they came from two different ethnic groups. But I think these kind of actions and behaviors against Black people or anybody that's in underrepresented groups, they did not happen overnight. And so the solution is not going to happen overnight. It's not going to be resolved overnight. So we need everyone around the table. And by everyone, I mean, this will include people of the Black community or in any underrepresented group, as well as people of the majority represented group. And I think it's really, really important for both sides to be around the table and to really hear. And it's important, I think your speaker before was talking about representation. It's so critically important to have representation around that table. If you only have males around the table, you're gonna get that perspective. If the minute you start bringing in different people, who have different lived experiences, and you start speaking together and brainstorming together, the number of solutions and the number of options and the number of positive things that can happen just kind of go up tenfold. And I always say that when you are, as healthcare professionals and as policymakers, when you get tired of hearing the conversation, of hearing things about racial inequality and hearing things about, discriminatory practices, et cetera, when you get tired of that, that's when you need to listen some more. Because you're almost at a breakthrough point when you're kind of almost reaching your fatigue point. So, I think for me, it's incredibly important that the conversations happen, continue to happen, even when the comfort level goes low. We still need to have those conversations, and that's because it's a process. It's not gonna happen. And it should not also be a tick box exercise. And I know, with my work, a lot of times, I'm getting called into a lot of these kind of conversations, and we have to be incredibly careful that we're not just saying, yes, we've done that, and it becomes a tick box, because people feel when you're being disingenuous. So it has to be authentic, and it has to be a process that we go through over the many years to come.
Thank you for sharing that, Gigi. And like you said, it's about having the conversations, even at times when they're uncomfortable. But that's one of the reasons we wanted to do these viewpoints today. Was it starts with a conversation. It starts to just get the wheels turning in somebody's head that, okay, you're right. Maybe I need to be looking at things a little bit differently. And I certainly know, just by conducting, these pre-interviews that I did with everybody and then our discussions today, I know that I personally, have had even my perspective change just in the last few weeks. So, Gigi, thank you so much for joining us and sharing your perspective.
You're welcome. Thank you so much for having me. Thank you.
Thanks.
Bye.
For our last discussion of the day, I'm going to turn it back over to my colleague, Amanda.
Thank you, Susan, and good afternoon. The National Coalition for Infant Health has long recognized the value of breast milk, human milk, for infants. We know a diet made up exclusively of human milk can be much more than food. It's quite literally medicine, proven to dramatically reduce risks for tiny babies, especially those weighing 2 pounds or less. So protecting infants from deadly necrotizing enterocolitis, sepsis, and other dangerous comorbidities, a diet of human milk can offer life-saving benefits. But as awareness of human milk's benefits has grown, so has an industry to meet the growing demand for donor milk. So today we explore an important yet complex question. How do we ensure that donor human milk is safe? Similar to human blood or plasma, donor milk is a biologic that can transmit viruses, bacteria, and toxins such as drugs. But donor milk remains underregulated by the FDA. So to take a deeper dive on this topic, I'm pleased to welcome two panelists. Dr. Martha Dawson of the National Black Nurses Association will join us again. Welcome, Martha. And we also have Scott Aker, Chief Operations Officer of Prophylactic Bioscience, which is the first and only company to offer a complete line of human milk-based products used in the NICU. So thank you both for joining us. Scott, now I know you served in the blood and plasma world for many years and then transitioned those skills to create what I understand is one of the largest human milk facilities in the world. So when you think about how the industry and the demand for human milk has exploded in recent years, do you see that as a good thing or a bad thing?
Well, I believe the growth of the human milk industry and the ability to provide human milk and human milk-based fortifiers and other products to babies in the NICU is absolutely a net positive. But that's required that there be a pretty huge increase in the amount of milk that is collected and processed to be able to keep up with that growth. And if you look at what's publicly available from the nonprofit milk banking industry, they are growing leaps and bounds each year in the amount of milk that they are collecting and that they're processing, and we're no different. But we have a graphic that I would ask that you put up that really shows how rapidly the industry has grown over the past decade. When I started with Prolacta back in 2007, there was a relatively small number of milk banks, all of them in the nonprofit world, that were providing milk. Since 2011, roughly, there's been an absolute explosion in the number of milk banks, and also importantly, in the types of milk banks. There are now both nonprofit milk banks and then milk banks like Prolacta that are providing other types of products. We provide fortifiers. Other commercial milk banks are providing different types of donor milk. And those donor milks are not all the same. And so what type of milk is provided may be incredibly important to you that are providing these products to the babies in the NICU. And right now, there's no regulation that specifically says, how do you collect milk? How do you process milk? And so while I do believe growth in the industry is absolutely a good thing for babies in the NICU, I think there needs to be some additional requirements, and including things like clinical trials for products that are novel.
So let me ask, for someone who's a decision maker in a hospital system or even a new mom considering donor milk, what are the hallmarks of quality and safety that we would want?
Well, I think as it's always been, how donors are selected, how they're tested, and how the milk is tested remains incredibly important. And understanding how your milk bank is doing that is something that I think every hospital that's using these products should understand. But as I said, there's also the processing of the milk, whether you're making donor milk or human milk-based fortifiers. And in the last few years, what we've seen is an increase in the number of donor milk products that are uniquely processed, whether that be high temperature sterilization of the milk, powdering of the milk. These are not things that are well established and tested. So for example, when human milk is subjected to high heat processes, sometimes up to and including commercial sterilization, certainly there's going to be a beneficial effect in terms of eliminating pathogens, and from a safety perspective, there may be an advantage there. However, you also have to recognize that those high heat processes are likely damaging some of the bioactive components in human milk. And we know that bioactivity is incredibly important to the effectiveness of human milk in preventing comorbidities of prematurity. So hospitals should really be not only looking at how the milk is collected, but how it's processed and what data exists to support that those unique processes that are being developed are providing human milk, donor milk, that's going to have the same benefit to the babies in the NICU. I think clinical studies of these products are absolutely necessary, and hospitals should be asking to see that data.
Thank you for that. So now, Dr. Dawson, you're looking at this from a different perspective, but also with a real interest in the question of safety and quality. In 2016, your organization, the National Black Nurses Association, adopted a resolution about creating a culture of safety in human milk. And part of that was requesting that the FDA clarify its plans for safety regulations. So is it safe to say then that you saw these coming, these safety issues?
Yes, our nurse leaders really became acutely aware of the different methods of screening and testing of human milk, and also the lack of consistency in best practices in the industry. So what we did is we asked our Women's and Infants Health Committee to do a deep dive into the literature and the science around this growing practice. And what we discovered really is there is no standardization, a requirement to ensure patient safety. And now remember, these are most vulnerable premature infants. And like we stated earlier today, again, this is another disproportionate, I would say, health issue within the Black communities. And the number of infant mortality in the African American and Black communities from this premature issue continues to grow. And so we know that there's potent benefit from human milk. And we also support and recommend that, at least for the first 6 months of life, that, we try to give infants, human breast milk. However, we have to be concerned about the safety.
So Dr. Dawson, let me ask you this. Sometimes regulation can have a dark side, right? Unintended consequences. And there are those who worry that FDA regulations could stifle the donor supply. I think there are others who might say regulations are simply unnecessary. How would you respond?
Well, my belief is quite different because I feel like it's an accident that is just waiting to happen at this time. So in the early 70s and I would say late 70s and 80s, I was a young nurse at the bedside in the ICU when we first started experiencing AIDS and HIV. And so when many patients during this time was dying because of tainted plasma, we had to stand up and take notice, and we have to take action. So no one knew until it was too late most of the time that it was coming from the blood product. Now let's add to this today, the pandemic that we're living in, and we don't know what is on the horizon. So this includes, legalization of marijuana, opioid crisis, the use of nicotine and vaping. So we must be forward thinking, and we have to be proactive to protect our infants. And so I really believe we already have a pattern that we can follow, and that is what we do with our blood and blood products. These kids are our future, so we have to protect them.
Thank you for that. Scott, can you share what FDA might consider in terms of regulating human donor milk in an ideal scenario? What would that look like?
Absolutely. I think current regulation of donor milk, and you said it at the very beginning, is under regulation of donor milk. Donor milk is basically considered a food, which is within the purview of the FDA's regulation. However, the food regulations don't really envision a scenario where you're collecting a biologic material from one person, processing it, and then delivering it to another person. Within the food regulations, however, any food that's intended for use in infants as a replacement for human milk is typically considered an infant formula. And there are specific types of infant formulas, most of those that are used in the NICU today, that fall into a subcategory called exempt infant formulas. And these are formulas that are designed to meet particular needs, medical needs of infants, and are subject to very tight regulation by the FDA, but also are allowed to have deviations from what you would see in, say, a typical infant formula. Our fortifier products, for example, are regulated as exempt infant formula. So we have conversations with the FDA on a regular basis about what's in our products, why it's appropriate for the infants. But most importantly, what this does is it requires that manufacturers have these conversations with the FDA when they bring products to market, especially products that may have a unique manufacturing process. It requires that you demonstrate through evidence, and that may be clinical trials with the product, that the products are appropriate for their use in the infant population. And it steps up the oversight from the FDA in terms of inspections. For example, we generally have the FDA visit us for a week or so every couple of years to check on what we're doing, look at our records, make sure that everything that we're doing is exactly as we said we would do. And now this would require that the FDA classify a donor milk product as an exempt infant formula. And that's something that I know we are working with legislators that are interested in this problem. They are asking FDA, how would that work? What are the challenges, and how can legislators help to make that happen? So I think there's interest both from our side in the industry, and then also from the legislator side in terms of seeing a higher level of oversight of donor milk.
Thank you. And thank you both for this. Go right ahead.
Yeah, I was going to ask, can I just add also that we have to understand that regulation protect both the recipient as well as the donors, and that we do support having a very safe supply of human milk. And we have to look back again, just at the historical aspect. When we began to regulate blood and blood products, that did not decrease the supply, but actually it started increasing the supply, and it made patients feel safer to know that there was some level of oversight to ensure that they were not receiving tainted blood. So I think we just need to take the same approach and move with our young infants when it comes to human donor milk.
Yeah, thank you, Dr. Dawson. I think that's a great point.
It is, and thank you both for this interesting look at donor milk safety. I appreciate the conversation today. That's all the time we have, but look for resources from the National Coalition for Infant Health on this topic in the resources section of today's live stream page. And keep an eye out for new educational resources on human milk and infant health in the coming months. Susan, I'll turn it back over to you.
Thanks, Amanda. And this now brings us to the close of the 7th Annual Infant Health Policy Summit. I hope you have enjoyed all of the views and the insights shared today by so many passionate advocates and clinicians and policymakers from around the world. I know that I have learned a lot, and I hope that you all have learned a lot, and I feel energized going into this next 12 months for all of the different opportunities there are for awareness and education and advocacy to help improve the lives of infants and their families. I want to once again thank our sponsors who made today's program possible, and just to remind you that these are companies and organizations who are working to improve the lives of infants and their families, and we are grateful for their support and their dedication to this population. To learn more about the National Coalition for Infant Health and the topics we've discussed today, please visit infanthealth.org. Thank you for joining us, and we will see you next year.